Morning, everyone. Thank you so much for being here and welcome to the 19th RMIE nursing, 19th RMIE. We added the nursing course a few RMIEs ago, but thank you all for being here today. We've got a full agenda, so we're going to go ahead and get started. My name is Lula. I am one of the interventional nurses here at UC Health and our GI department. And then we have Carrie Davis and Amy Corcoran as well. They're here as part of the nursing course as well. So as GI endoscopy nurses, we have an extremely broad scope of skills that rely on our places of work. RMIE gives us a chance to learn more about the procedures we participate in and the patients that we care for. We hope today that you will leave with new knowledge that you can apply to your current practice. We have an exciting lineup of live cases and lectures today. Our live cases will be moderated by Dr. Shaw, our director. He is the reason this all happens. Then myself, Carrie, and Amy one of us will also be up there with him, talking through things from a nursing perspective as well. So first, we will be watching Dr. Sachin Wani place an esophageal stent. That will be followed by a lecture about endoscopic mucosal resection by one of our other interventional nurses, Marcy Pilot. Next, we will witness a second live case performed by Dr. Larissa Muthing, and that will be a colonic resection as well. So it'll be great to have that lecture and then see it. And you've noticed that your agenda's changed a little bit, so I'm just going through those changes now. After that, it's our pleasure to welcome back visiting physician Dr. Eric Momini for his lecture on pancreatic pseudocysts. And then we'll round out the morning with a lecture given by Carrie and Amy speaking about endoscopic myotomies. Then we'll break for lunch, and after that, I'll be giving a presentation on Barrett's esophagus. And we will finish up our last talk with one of our amazing physician's assistants, Colette Crane, and she will be giving a talk on endoscopic ultrasound and ERCP. For each lecture and live case, there is an allotted amount of time for questions and discussions. So if you have questions, please save them till the end of each lecture, and hopefully we can get those answered for you. So we are just getting ready to broadcast our first case, but we have a little bit of time. So I figure we could go around and I'll grab a mic and just introduce yourself and say where you're from and what brought you here today.
Hey, good morning. My name is Annie Paulson. I work in health economics and market access for Boston Scientific, and I'm here from the East Coast, hoping to just learn a little bit more from the clinical side to apply to the economic side.
I'm Kate. I'm a tech. I work in the GI department at Poudre Valley Hospital, and I'm just here to learn more.
I'm Jen. Ooh, sorry. I'm a nurse at Poudre Valley Hospital, and I just love this stuff. Yeah, so much. So grateful for you guys.
I'm Lila. I'm a luminal nurse here at the main campus, and I think this is my second or third year attending RMIE. Take care of these patients in pre-op and recovery, so just adding to pre-existing knowledge.
And I'm Ariel. I'm also a luminal nurse here at UC Health. This is also my second year attending. I really enjoyed it last year. I learned a lot, so I'm excited to learn more this year.
I'm Erica. I'm also a luminal nurse here, here to learn more.
Hi, my name is Melissa. I'm a luminal nurse here at the Anschutz campus, and I'm here to learn everything I can.
Hi, I'm Hannah. I'm from Colorado Springs, UCH GI lab.
I'm Kristen. I'm a nurse. I'm from Henry Ford, Detroit, and I'm here to learn more.
I'm Amanda. I'm also a nurse from Henry Ford in Detroit.
This is my first GI course, so I'm super excited to see what we learned today.
My name's Megan Worf. I am the nurse manager for these lovely nurses from Henry Ford, Detroit, supporting one of our faculty who's giving some talks tomorrow.
Hi, my name's Taryn Hardesty. I'm the nurse manager of the GI lab here and came to watch some of my girls present. I'm a proud mom over here, so really excited to watch today.
I'm Shelby Evans. I'm the associate nurse manager here at UCH. Just here to watch the presentations.
I'm Roberto. I come from the VA Minneapolis. So yeah, I'm just here to learn.
My name's Alex. I'm also from the VA in Minneapolis.
My name is Caitlin. I am down at the UC Highlands Ranch GI Clinic. And we're just excited because we're finally starting to do therapeutics more often and figured can bring some stuff back to the rest of the group.
My name's Alex. I'm also from the UCH Highlands Ranch. Pretty much what Caitlin said, just this is the second year I've been here. Learned a lot last year and hope to continue to build that.
I'm Ashley. I'm one of the interventional nurses here, so I'm just here to learn more. I'm very excited.
Thank you all. I appreciate it. It's really cool to see how far some of you guys have come from. So welcome. I'm just going to make sure we're ready for our first live case. I'm going to invite Dr. Shaw to come up. And then Amy Corcoran is going to be moderating with him.
All right, good morning, everybody. We have our first case. Thank you, Lula. Thank you, Carrie. It's a fantastic agenda, and we really value the relationship that we have with our nursing and MA staff. Really one of the best in the country, if not the best. This is a patient Dr. Wani is going to be evaluating, a 73-year-old male with a 3-month history of progressive dysphagia. Initial CT showed possible gastroesophageal junction thickening. An attempted EUS in June at another hospital was unable to be performed due to the esophageal stricture. It required laparoscopy, J-tube insertion for nutrition. Interval MRCP in July noted a 3-centimeter cystic lesion in the pancreatic body. That was the initial reason for the EUS, I think. Repeat EUS here also was unsuccessful due to a severe stenosis. So an esophageal stent was placed with a stent fix to facilitate EUS scope passage to evaluate the pancreatic cyst. Repeat EUS was done September 5th. He told me that he was tolerating a grilled cheese sandwich the night before. He was pretty happy with the stent that was in there. But when I did the endoscopy, it showed stent migration of the stomach. And over the last week, so I thought he'd do fine without a stent, but turns out he's having worsening dysphagia in the last week and is here for consideration of esophageal stent placement. This is the appearance of the stricture prior to intervention on the left, and on the right, an esophageal stent placed with a stent fix back in August. Next slide, please. That may be it. So I think we can go live to the room 14. And we have the fine Dr. Wani here. Can you hear us? Okay.
Raj, can you hear me?
We can hear you now. Yes. You look great.
I was about to ask you, how do I look?
Well, yeah, you look good.
Okay,
you look
perfect.
Great.
Thanks.
You look great, actually. Yeah.
Thanks. I want to start off, Raj, by congratulating our course directors. I also want to take the time to introduce our team members here. So we have Summer Fry and Christy Tronick. And then we have Sarah who's giving us anesthesia. She's hiding behind the camera. But I just want to echo, Raj, what you said earlier. It is true. We do work with the best nursing staff, period, in the country, I would say in the world. So these are folks that I would trust with my own life and with my family members. So let's get started with the case. As you pointed out, this is a patient with a complex and fairly severe esophageal stricture. What is interesting this time around, Raj, from the picture that you showed earlier, is the fact that there is obviously a significant amount of ulceration at the site of the stricture. Now, the working diagnosis for this stricture at this point is that this is reflux related. We've not seen any mass in this region. This was not identified previously either. And you're right, Raj. Once you took the stent out, within 3 to 4 days, he started complaining of dysphagia. So our plan is to obviously evaluate the stricture. One thing I will say is that you want to ensure that you're not missing underlying malignancy when you're evaluating esophageal strictures. And as I said, for the most part, this looks like a reflux-induced stricture. Is the endoscopy feed coming through okay, Raj? Can you guys appreciate what I'm seeing on endoscopy?
Yeah, we can see the endoscopy view, the fluoroscopy, and then we can see you as well as partially your hand movements as well.
Oh, terrific, terrific. So here's what we're going to do. As you can see on fluoroscopy, where my scope position is, and now, given the fact that I am not able to pass my standard upper scope past the site of the stricture, I'm going to pass a guide wire. We typically use an 035 long wire. You can even use a savory wire if you want to, but my go-to device is a 9 to 12 balloon. And can you see Summer, by the way?
No, we just thought you were doing the procedure all by yourself, Dr. Wani.
Yeah. Summer, you want to
Are we,
step
are
in
we able
here?
to zoom out the camera a bit?
Yeah. And,
Hi.
okay, say hi to everyone. Okay, perfect. All right, so now
If you're
I'm
able
going to
to zoom
pass.
out so that we can see both Summer and Sachin would be great.
And did you guys say hi to Christy?
Hi, Christy.
Right there. Okay, so what I'm doing now is I'm passing a 9 to 12 balloon down and get a wire across this stricture.
So, in some circumstances, such in the scope, you're using fluoroscopy here because you're unable to traverse the stricture.
Correct. Great point.
I guess there
Yes.
could be scenarios where you could pass the stricture and then advance the wire without the need for fluoroscopy. Because I know some of the endoscopy labs may not have fluoroscopy readily
Exactly.
available.
Summer,
And
go ahead, pass the wire.
Advancing the wire. It's going easily.
Okay.
Going easily.
sometimes you
So
can
one
consider an
important thing.
XP. Yeah.
Sorry, Raj, to interrupt, but I just want to make this point. This communication between you and your nurse is absolutely critical. I don't know if you guys could hear Summer say that, okay, I'm passing the wire, I'm not feeling any resistance. So this sort of communication is absolutely critical, relevant when you're doing resections, ERCPs. It really doesn't matter, but this is just something that we really value in our lab. Okay, so you can see that my wire has gone past the stricture. You can see that it's in the stomach. Summer, go ahead and advance the wire some
Advancing.
more.
Summer, could you comment
Advancing.
on what maybe for the newer nurses especially, when you're advancing these devices, there's some resistance that's acceptable, some not. How do you distinguish that? And when do you think pushing the wire, too much pressure versus not enough? you're a seasoned nurse here, so we'd love to hear your opinion about that.
I think starting off, if you're not sure, you should always just stop and say, I'm feeling something and I'm not sure. Because that keeps your trust with the doctor and it logs your experience. And then as you get more used to feeling things, you'll feel more comfortable with what's a normal resistance and what's not. And so you'll feel something like something's moving through like a device, but it's not, it shouldn't feel like you're hitting a wall. Like, and if anything feels weird, you should always stop and tell your doctor.
Perfect. So now you can tell that the wire is nicely placed in the stomach. I know from Raj and Bilal's previous procedure that this is really a short stricture, but what I'm going to demonstrate to you is how we define the length of the stricture using our fluoroscopy and injection of contrast. So what Summer is going to do is she's going to inflate the balloon to 12 and then overinflate by 2 more, just so that I can get a good sense of how tight this stricture is.
Okay,
Okay, let's go ahead and inject, and then Summer, I'm going to pull the balloon back, and if you can ensure that the wire is pushed in as I come back. All right, so let's go ahead and inject contrast. And now you can see that all this contrast is just going into the stomach, and you can tell that by the rugal folds within the gastric wall. Now, as she's injecting, I can start to feel some resistance right here. And I suspect that's where the gastric cardia and the gastroesophageal junction is. So with that in mind, I need to ensure that my stent actually crosses this area where I'm feeling resistance. Okay, so this is where I'm going to ensure that my stent traverses this area. Can I get the marker, please? Okay, so what I'm using now is a paper clip, and we'll talk about different techniques that you can use when you deploy esophageal stents. So obviously, I'm just going to put this on the patient's back and hope that I'm at least close. So I'm not.
The guide wires here, endoscope, the clip, so he's just kind of trial and erroring. He's at the
Right.
top of the stricture endoscopically, and so this is the clip. He's getting a little closer. And notice that we have a shield also. We have a shield here. There's actually a drape, a lead drape around the bed. There also is a shield here to reduce any
Okay,
scatter
that's great.
from the image intensifier or the flat detector. And so
Okay,
he's careful
now
to try to use that.
come down on the balloon, please.
So Sachin, this is in the, you have this clip at the top, or yeah, straightened out paper clip at the top of your stricture where the endoscope was, correct?
Yeah, so the clip is actually at the distal end of the stricture, and I'll show you what the fluoroscopy looks like when we inject to define the top. So someone, let's do the exact same thing again. Go ahead, overinflate.
All right, I'm overinflated by 2.
Okay. Go ahead, inject, please.
Is that balloon going through there pretty easily?
No, it did not actually. So this
Okay.
is the top. Inject. So you can see a lot of the contrast is coming back,
Are
but
you
I
able
feel
to
fairly
mag up the
comfortable.
fluoro?
Say that again, Raj.
Are you able to mag up the fluoroscopy
Oh,
image?
you bet.
Okay, thank you.
Yeah, of course, of course. So as long as my stent goes past this clip, I'm going to be comfortable with the deployment. So let's go ahead, drop the balloon. Let's inject. Let's exchange. So this is a fairly short stricture, Raj, so we don't need to put in a super long stent. So I'm actually going to choose a 10 centimeter stent. So let's do a 23 millimeters by 10 centimeter fully covered expandable stent.
Sachin, could you go through sort of how you selected that length? Because you first started with saying that it was fairly short, and then you used a 10 centimeter. What type um, of guidance are you using as far as length of stricture and above, below the stricture?
Yeah, great point, Raj. What I have noticed based on our experience is that 7 centimeters can sometimes be a little too short, and especially given the fact that this patient has had stent migration, I want to give myself the maximal benefit from stenting, especially if there is even a little bit of migration. The stent should still stay in position and treat the stricture. So this area of narrowing is about 1 to 2 centimeters at most. And then the rule of thumb is that you should have about 2 to 3 centimeters above and below the stricture. So you add 6 plus 2, that's 8. So I'm giving myself some wiggle room, and that's how I'm selecting a 10 centimeter stent. Does that sound reasonable to you?
Yeah, definitely. Thank you.
And here we want to show you the stent before we go ahead and deploy. This is the stent that we are going to be deploying, and I'll show you what this looks like once Christy takes it out of the package. This is what our nurses do consistently, especially when you're placing devices. They always confirm with the endoscopist that they've grabbed the right stent. We've had instances where not within our center, but outside, where the wrong stent, where the intent was to place a fully covered and an uncovered stent was placed. So we do everything in our capacity to avoid that situation. All right. So
So 1 second,
go ahead.
Sachin. Well, while you're working there, I think we wanted to ask about the exchange.
Yeah, so Summer, you made that look really smooth, pulling the balloon out, but knowing
Okay, grab the
how
wire.
it works, you didn't just like pull. So do you want to talk through, I guess we're doing sort of two exchanges right now. She just did one with the tool. So she's having to push the wire while removing the tool so that she's not pulling the wire out. But now, again, they're sort of doing an exchange with the wire. So wire has to be pushed while either the tool
Okay.
or the scope is coming out in order to
Uh-huh.
not move the wire. But I guess, Summer, did you want to talk a little bit about like the feel and the communication with Dr. Wani when with the exchange?
I can't hear.
Yeah,
I don't know.
Raj, you may have to field this question because both Summer and I could not hear the question clearly.
Really? No, so you want to try again?
Can you hear me now?
Yes.
Okay. I was just, we were watching your exchange, but I think it would be good to sort of explain what you did there. I guess with the balloon first, where you were pulling the tool out. So we call it a 9 to 12 balloon. What did you have to do and how did you communicate with Dr. Wani when exchanging?
So exchanges are tricky. You have to match the rate of the opposite of whatever the doctor's doing. So if they're pulling a device out, you're pushing your wire in, and you essentially want to have the wire not move. How I was able to know that I was not having the wire move was watching the endo screen. You can watch the like sort of like the markings on the wire like stay still. If for some reason you were unable to see that wire, it wasn't visible yet, your doctor would provide you fluoro. And if you're feeling like you're not sure what's going on and you don't have fluoro, you can say, can I have a fluoro spot just to see what's happening to make sure my wire didn't move?
Yeah.
So those are the two ways that you can do it. You're either using fluoro or you're using the wire itself.
Great.
Also, on top of that, I think is just you can use the word stop or hold on or something just in case you need some clarity and you're not quite sure where that wire is. We often try, as the endoscopist, to minimize the use of fluoroscopy. But if you're not quite sure where that wire is, just asking for that when it's necessary can be helpful too.
Yeah, and then on that note, like when you have a really long wire, like I have it curled in my hand right now, but if I'm doing back tension and I'm making sure that wire doesn't move, but I need to do something with this hand, I just say stop. And then I address what I need to do and I say, okay, continue. So it's okay to have needs and it's okay to communicate those. In fact, that's encouraged.
And you
I
may
would
have
say,
noticed this
yeah.
when we were removing the endoscope. It was really important, obviously, not to lose your wire, right? So I was pulling the scope back, and Summer was pushing the wire. And then as soon as we got to the end, I continued to pull out, and she grabbed the wire and she told me, I have the wire. And then once we took the scope out, she made a turn with the wire, and at all times we maintained access to the wire that's at the patient's mouth. Once I was in a position to grab the wire, I held the wire and I told Summer I have access so that she can then grab the distal end of the wire and advance our stent over the guide wire, which we're ready to do, by the way. So, Raj, tell me if you can see the stent clearly.
We can see it great. I'm wondering, is that left? That must be a in-room. I don't know how you're getting these images, but it's great.
Okay,
Because
terrific.
we see left and right hand, the entire delivery system, almost the entire, and we see you as well. So thank you.
Oh, that's great. So you can see the delivery and the system at the end of the
Yes,
stent,
we see
right?
that.
So Summer, why don't you tell them what you're going to do before we actually start doing
Sure.
the deployment?
If you can
Yeah.
lift it up
So
just a
when
centimeter or
he's
so.
when he's putting the stent in, I'll be maintaining back tension. It's similar to like if you're used to a savory. So I'm just giving some gentle back
Could you
tension
just
so
shift?
he can.
Okay.
Oh, now we can see.
Yeah.
Sorry, Raj, you wanted us to show something?
No, no, it's good.
It's
It's good.
great.
So you're using fluoroscopy here. You have
Correct.
a forgiving wire, um, flexible tip wire. So not
Yep.
as concerned about any mucosal trauma if the wire goes a little too far.
So now you can see that the stent is beyond my marker. And as I had mentioned previously, we want to ensure that we have at least about 2 centimeters beyond the end of the stricture, which is what we're going to aim for. And when we're ready, we're going to get rid of this lock, which prevents the stent from being deployed. And then Summer and I will communicate with each other as we deploy this stent. So I feel pretty good. One other thing to remember is when you're deploying these stents, I'm okay with it being deployed a little distal because you can always grab the stent and bring it up. What you don't want to do is deploy too proximal because then you're in a situation where you have to take the stent out and grab a new stent and start all over again. So you can see that I'm going to keep a decent amount of the stent distal to this paper clip. So we're now ready to deploy. So Summer, go ahead and start deploying. And I am using fluoroscopy at this point. Go ahead.
Okay, so when you're starting to deploy, there's two little like flanges you'll hook your finger on. They're actually labeled. One's got one, one's got two. The longer ones actually have a third one. So I'm gonna say I'm starting to deploy, and then I'm just putting some gentle pressure, but it's gonna eventually jump. So I'm gonna kind of make sure I am prepared to kind of pause so he can accommodate for that.
And what you're really looking for is a nice flare at the end of the stent. You can see it's opening up now.
Continuing.
Yes, please.
Do you ever use an endoscope side by side to see how the position is
Oh,
approximately?
yeah. We do that all the time, Raj, especially when we have to do this emergently in the intensive care unit hold on, where you may not have access to fluoroscopy. So that's the technique that we use very often when we have to do it bedside in urgent/emergent situations. So you can see, Raj, that the distal end has flared up nicely, and I feel good about this position. And you can see that Summer has deployed the distal portion of the stent, and now we're going to start working on the proximal portion of the stent, and she's going to bring flange number 2 all the way back to the end of the delivery catheter. Summer, when you're ready, I am.
One thing I'll say, just so you're not alarmed if you're doing this roll, as he's giving back tension to maintain where the stent's going, he's actually starting to deploy the stent on his own. So if your doctor is like, stop deploying, but you're like, I'm not doing anything, you're not doing anything wrong. Like they actually start deploying the stent. Even on this last one, even on the first stage, he started deploying on his own. So I can stop doing nothing, but it's still going to keep advancing. And you're not doing anything wrong if that happens. It is just you're like, oh no, what's happening?
All right.
You ready?
Perfect. Yep, let's do it.
Dr. Wani, do you think you're gonna stent fix this just because last time it migrated?
Yeah, great point. That's my point. I'm actually going to throw the kitchen sink at this case because of the fact that despite having a stent fix the last time, the stent migrated. So this time around, I'm actually thinking of putting two different stent fixes clips at two different sites of the stent. That's a great point. So you can see that the stent is deployed. It looks okay, and you do want to take a look at the delivery catheter as you bring this past the side of the stricture. Especially if it's really tight, you may feel some resistance as you bring the delivery catheter out of the stent. I did not feel any major resistance, so I feel good about this. So yeah, now we're going to bring everything out. The wire is out. I'm going to now go down, take a look, and see what the stent looks like. And then you always want to document in your note what the proximal site of the stent is.
It's very nice waist that we see
Yeah.
fluoroscopically, and you got a fairly centered position here. Another thing we like to see, a nice expansion proximally too.
Yeah, and I tell the trainees this too, that it's very tempting at this point to just drive your scope past the stricture to see what's happening distally. It's okay to do this most of the times, especially if you have an XP scope, but resist that temptation because that may result in stent migration, which we obviously don't want. So I'm pretty happy with the final image here, and you can see gastric contents coming up, right? So the proximal end of the stent is at 40, and the stricture was at 45. So I've given myself about 5 centimeters, and our goal is to now put the stent fix across two different sites.
Any questions from the audience?
Maybe, Raj, we can talk about
Lila?
what the management is for patients after you place stents. How will nurses address management of patients after they've had an esophageal stent? This can be fairly painful for some patients, whereas some do just fine, right? So recognize that some patients may come out complaining of severe abdominal pain
Hey,
after
Sachin, could you
stent.
explain what you're doing here? Because I think some of the nurses, techs might be interested in what you're doing there. We can see
Yeah,
it, but if you can just explain the.
absolutely. So this is the stent fix device. This is the handle. Do you have the box that I can show them? All right. So this is the Ovesco stent fix over the scope clip. The whole concept of this is to again prevent stent migration. The delivery device and the setup is very similar to putting an Ovesco clip for management of fistulas, perforations, or bleeding. What you need to remember is you need to take your cap off, and remember steel to steel, right? So this handle has a steel component that gets connected to the steel component of your endoscope. Then the next step is to grab that clip which you and attach it to the distal end of the endoscope. And the concept is very similar to how you would attach your multi-band mucosectomy device, or how you would connect your variceal band ligation device. So I'm passing this through the opening in the handle, going through the therapeutic channel here. And then you can see Summer connecting the thread to that groove at the end of this catheter. I'm bringing it back, and you can see Christy unraveling the stent that's attached to this piece of foam. And then, Christy, before I get too far, do you want to just show the clip, what it looks like on the catheter? If you can just hold it. Can you see this, Raj?
Yeah, we can see it. Looks pretty similar to like what your bands would look like.
Exactly, exactly. One thing I will say is that we all need to be careful when we are working on this to ensure that you don't accidentally deploy this over your finger or any body part. That would not be good.
We've got a question here, so we're going to take Lila's question real quick.
Sure.
Hi, Dr. Wani. I was wondering if you could just comment on sort of how you prevent ulceration and sort of tissue erosion with the stents, especially when they're metal for these patients.
Sure. Can someone just repeat that question? Just give me 1 second
So
here.
she's asking about tissue erosion, ulceration. What are you doing to prevent this or watch for this?
Yeah, great question. I mean, having erosions or ulceration after stent placement is very common. And you just need to ensure that the patient is on maximal acid suppression, which is what we're going to do for this patient. And I think your question is even more pertinent given what we think the etiology of this stricture is, right? We think this is reflux related, so making sure that we manage the reflux appropriately is important. So he'll definitely be going home on BID PPI therapy if he's not already on this. So now you can see, you may or may not have seen this, where I had the cap put on the scope. I sometimes put a little bit of lube right at the tip of the endoscope, and then I push the clip down onto the scope using this piece of foam that's included within the kit. Again, the idea is that you shouldn't be doing it with your finger and pushing it down, because you could accidentally deploy it, and that could be on your finger, which again, you don't want. Okay, so now I feel good about where the clip is, and I'm going to go down and identify a spot where we're going to deploy this clip. Sometimes it can be a little more difficult, especially if the patient has any proximal strictures. So the endoscopist really needs to be careful about passing this down the oropharynx and the proximal esophagus. The other thing you'll see is that I want to ensure that I don't deploy this at the site of where this hook is. This is what you're going to grab when you want to pull the stent out. So I like this position here. I'm going to get close to where the proximal end is. Once I feel good about this, I'm going to get even closer to this, and then I'm going to suction. I feel good about this. I'm happy where that is. And there. Now you've grabbed the esophagus, you've grabbed the stent, and the stent, this clip is now deployed. I'm fairly happy with where it's deployed. You want to
That looks
obviously ensure that you've grabbed the wall to prevent migration.
that looks really good, Sachin. When you were doing the suction, did you turn up suction maximally? And also, do you look for a readout like we do with varicose banding, or
Yeah,
what? Is it more of a feel?
Yeah, it's more by feel. I would have loved to see a better read out sign, but I felt fairly comfortable. But you're right, that's what I look for. I try and get a little more capture, but ultimately I felt that we achieved the goal of placing this stent fix.
Such a fantastic demonstration. Thank you. Are you going to plan a second Avesco and then we're going to go to lecture
Yeah,
while
that's
you're
the
doing
plan,
that?
Raj.
Summer, thank you so much. Christy, thank you. It's fantastic.
Thanks, guys. See you
Thank
soon.
you.
Bye. Okay.
All right, we're gonna start our first
This was interesting.
lecture.
Look at this, Summer. This didn't go all the way. See that? That's weird. But still, thank God
Um,
it worked.
I'm going to invite up Marcy Pilot. She is one of our interventional nurses. Marcy has a unique perspective working in multiple different endoscopy labs, as well as one of our nurse navigators. She's a wealth of knowledge, and I'm very excited for her talk.
Well, good morning. Thank you for the great introduction. First, to start off, thank you for attending RMIE. This is where I feel that our department shines. We do want to deliver the best care we possibly can for our patients, and I think this really showcases how we can do that. Now, I know there's been a lot of advances over time and a lot of equipment that changes over time, but ultimately the nurse's role is still very similar. It's to support the physician and to support the patient. So with that, we're going to discuss a little bit of CMR or EMR. You can either, do both of these kind of at the same time. So we want to discuss how we're going to take out said polyp. We are going to have several different videos, nothing real exciting or nothing real scary or anything. We're going to discuss the tools, whether it's physical or whether it's just environmental. Also, we're going to want to discuss the risks for our patients and how to manage that after. So here's a short video on a hot snare. You can see they're using a lifting agent, unclear on which one, but it does look like there is some blue there. You'll see in a moment they're going to open the snare, and obviously that entire polyp is not going to fit in that snare. So they're going to do it piecemeal. What's important about this is to make sure that you have a plan for this piecemeal polypectomy. You don't want to leave islands of tissue. So they're starting on the left, and they're using that first cut area to anchor the snare into that and to close. Of course, those submucosal fibers look amazing. There's no muscle in there. Muscle would not show blue. It would be white. And I did borrow some of these slides from one of our doctors, Dr. Bilal, so I cannot take credit for any of the videography on this. Oh, okay. And we stopped. All right, well, we'll just go to the next one. All right, so my question is, how many people do hot snare CMR are familiar with this? Okay, so a fair amount. So we're also going to now go into cold snare, which is basically not using cautery. These can be used for your sessile serrated adenomas, still that needs to be taken out. And here they decided to use a blue lift again to better define the polyp. The polyp will not take up the blue, so it helps define those edges really well. All right, still injecting. And at this point, I'm thinking to myself, is the snare going to slip over the polyp the entire time we're trying to remove it? All right, it looks like here they're starting to open the snare. It looks like they're using a lesion hunter just based on the tip here. It's one of the cold snares on the market. It's pretty sharp, has a nice click to it, so it's very satisfying to cut that polyp off. And again, they're going to use a piecemeal technique to move around and get the edges of the polyp along with a little normal mucosa for better pathology and prevention of reoccurrence later on. And you also notice in this CMR that they are using a cap to help hold down the folds, better to move things around. Also, they'll use it to suction mucosa into the cap to grab a bit bigger suction or bigger piece of mucosa. Again, we're seeing a nice blue submucosal lift there. No white muscle, which is fantastic. And they're still going.
Just look at the celery.
All right, and that's kind of your end result there. Next slide is very short. So what we started doing here a little bit with the addition of Dr. Bilal to our practice is underwater EMR, and you can do this whole cold or hot. And basically what we're doing is using the weight of the water to help separate the mucosal layer from the muscularis area. So this way you're not having risk of perforation. The things to know when you're the backup or the nurse for this, make sure you have at least 2 or 3 liters of saline on your back table because you will go through all of it. Make sure you also have a lot of suction, whether it's the canisters or whether you're using a Neptune type situation, whatever it is, make sure you are prepared for all of that. So now we've seen a couple of the different techniques. So let's talk about the tools. Now we all know about the physical tools for CMR. You know, we have our snares, we have our cautery, we have our injection needles with lifting agents, we have polyp traps, you know, clips and Puristat and coag arresters. We have all of these things, but let's talk a little bit about the mental. Where are you doing your procedure at? Are you in a surgical center? You come, you're doing screening colonoscopy in a surgical center and you find a 4-centimeter polyp. Is this provider have the ability to safely remove this polyp? Because once you start injecting, you are committed to now removing this. So you want to think to yourself, okay, fine. We're 3 hours behind, but it's okay. We're going to take this 4-centimeter polyp out. Can we manage the complications? Do you have the tools to manage the complications? Do you have an Avesco type clip to be able to seal a perforation? Do you have regular clips? Do you have a product called maybe something like Puristat or Hemospray to help with bleeding? These are all things to consider as you're looking at this polyp. But also what's most important is the physician looking at the polyp. Now, are they using a cap? Are we going to be able to see the entire polyp? I've been in situations where you look and, oh, it doesn't look so bad. And then all of a sudden you look behind the fold and you're going, oh, that's definitely different. So now we need to consider Are we able to do this? Is this 5 o'clock at night and we still have 3 more procedures to go? These are all things that as a team, we want to make the best choice for the patient as nurses and techs. We have providers here that say, you know what, we don't have time to do this polyp today. Let's reschedule them. That's okay. We would need to make sure that we feel empowered to do what's in the best interest of the patient. So, couple of slides on the snares here. Obviously, we have a bunch of different sizes. We have a bunch of different shapes. We have cold, we can have hot. There is even a needle on the market that also has a snare attached to it. We can do that. Your snare is not up for your picking, obviously, but it is up to the provider, making sure that maybe there's that conversation ahead of time. Like for us, we're lucky. We're a referral center. So the community is sending us our patients a lot of times. We're not doing screening colonoscopies and interventional generally. So we can look at the pictures. On the front side, our nurse navigators request the color pictures. They request the pathology if there is any. And the physician has all those tools to make the decision. Are we dealing with something with high-grade dysplasia? Is there some maybe center depression or ulceration that maybe a polypectomy is not enough or an EMR is not enough and we need to consider ESD? Usually these patients are seen in clinic first before they even come to us. So we do directed procedures. We're not doing a whole colonoscopy necessarily. We're saying, okay, well, we got a referral for a descending colon polyp at 30 or whatever, or sigmoid, and we're going to go in and we're going to take that off. Then the patient's going to come back in 3 to 6 months. We want to assess our area. We will look at the rest of the colon usually at that point, just to make sure that there is nothing else going on. Then at that point, we send them back to their provider with our recommendations. Another screening colonoscopy in a year. And then depending on number of polyps, where they're at, there's guidelines for that on the physician side. If there's so many tubular villus adenomas, they'll come back at a 5-year period versus a 7 to 10-year period. So as far as the nurse goes in this role, I'm very passionate about making sure my patients are safe. I just want to make sure we're doing the best for them. So we also have now polyp traps. A couple of different kinds in the market. We tend to use the one here. I think it was my no, okay. So the one on the left is the one we have at our department. We've used the other ones throughout my career. I have the multiple channel ones. I may have put a couple extra polyps, so the physician may not have been happy with me as I had 2 polyps in this from this different locations in the same container and didn't know which was which. So just be aware of that. Also, we do, you know, when you're doing your hot snare polypectomy, we are using cautery. This is just an example of what we do here. There's no set in stone program or any of that. So don't look at this slide and tell your provider, you know, I was at this course, this is what we should do. That's not necessarily the case. It's going to depend on the type of cautery you have, whether it's an Irby or something else. Also the age of it. That will determine what different kind of settings you have. Some of the older Irbies have stuff that's different than the current Irbies or the newest ones on the market. So just know that that discussion happens before we start cutting. We have the patient grounded. We have the Irby in the room. What do you want next for your settings? Some of ours are pre-programmed because that's what our providers like. So it's easier for us. But you know, not knowing your other providers or how many different ones you work with, just always verify. Just like opening the stent in the video, verify with the provider. All right. So risks of CMR. Again, on the nurse navigator side, I would get these calls after the procedure. I would try to touch base with all of my patients that I supported for my providers prior to their procedure to prepare them. I would already lay the groundwork prior to the procedure saying, well, you know, we're going to take out this polyp for you. We're going to schedule you on such and such date. Make sure you have a good span of time. You know, that, you know, your procedure could be 2 hours long. And bleeding. You might have bleeding afterwards. That's okay. If you take out a cold polyp, you're going to have some bleeding. The problem is, when is it an issue? When is it not? Is it a couple smears on the toilet paper, or is it turning that toilet bowl red? That would be an issue. If there's clots in there, again, that would be an issue. What do you tell your patients? Where do they go? Come back to us. Don't go to another hospital. If they're somewhere in Nebraska, still come back to us as long as it is safe to do so. This is where your assessments come in. Are you dizzy? Are you lightheaded? Are you sweaty? Okay, fine. If it's a true emergency, go to your closest hospital. But ideally, I want them back at our hospital. We want to take care of our own complications. That should not go to another provider. Also, afterwards, in this, we're going to talk about maybe considering a softer diet for a couple of days. We don't want anything scraping off our effects of our closure, whether that would be clips, whether that would be a Puristat type of thing or Hemaspray. We want to make sure that we're providing the patients the best opportunity to heal. It's going to take a while. It could take up to a month. So most of the amount of bleeding is going to be in the first 2 weeks, but it could be up to a month, especially when we're looking at our 7 or 8 centimeter large ESDs. Also, we're going to talk about NSAID use. Also on that, on blood thinners. There's a ton of them on the market. It's not up to us. It's up to us to prepare the patient. So we want to make sure we're preparing the patient like, okay, afterwards, we're probably going to hold your, Plavix, whatever, for a day. Maybe they're working with a provider and they say, you know what, it's okay. Why don't we just put you on aspirin in that bridge period? Maybe they'll do a Lovenox bridge. We do have a pre-procedure services clinic here. Sometimes we'll send them through, but a lot of times we're going to be having the patient speak to their prescribing provider on that. We don't make those calls here. They know the patients better with the risk, and we want to provide that information from their provider, so their provider also knows that they're going to follow those instructions. Perforation, obviously, we talked a little bit about that and about how we are going to make sure we have the tools on hand if we can. We have been in situations where it's late at night, we're doing a procedure, we pull back the scope and we're like, oh, now we're seeing fat globules and we have a perforation. What do you do? Remain calm. That's the first thing you can do. Ask the provider, okay, well, it looks like we have a perf. How do we want to handle this? How big is it? In my mind, I'm already assessing this going, it's too big. It's 3 centimeters. We can't use an Endoscopy possibly on that. Maybe we have suturing. There's a couple of different suturing tools on the market. There's like NXT, there's your standard like first gen Apollo stuff, and I forget the name of the third one that we have here. Some of them we can use with a regular EGD scope. Saves time. Setup's a little cumbersome though. In the setup, you also want to make sure that you know what you're doing. Do you have the tools mentally also to know what you're doing? I have been in a situation where we have called the rep. Okay, we're in this situation. I FaceTime them. Can you look at this and make sure I'm good? I think I know what I'm doing, but I want to make sure also, and that's okay. I am okay with my limits and telling the provider, okay, I think I've got this, but let me double check. Communication is your biggest tool in your tool bag for any endoscopy procedure. Also, we want to talk about recurrence and incomplete resection. Since we are a referral center, we come across polyps where the doctor has worked on it 3, 4, 5 times. And now we're like, oh, how do we take this out? We are very lucky here to have providers that will do a full thickness resection, where we basically are taking a cap and bringing up the muscle and the mucosal layer all within that cap. And then we take everything off, send to pathology, hopefully get clear margins. If we do not get clear margins after that, they're probably looking at surgery. Reoccurrence. How to prevent that? Your providers, I'm sure as you guys have seen with other CMRs and as you're going on in your progress, they'll kind of APC or they'll just burn the edges of the polyp. That is shown to decrease reoccurrence at that site quite significantly. And since colonoscopy still remains one of the best ways to prevent colon cancer and removing polyps, to add to that, this is so important just for patients moving on, and especially now that we're seeing polyps and cancers starting to occur in younger patients. I mean, I don't know what you guys are seeing in the community, but here we're seeing 35, 40-year-olds with colon cancers. And at this point, they're now metastatic. So we're not managing a polyp at this time. We are now managing the complications from that metastatic disease. So it's just something that I'm very passionate of making sure that people know how to do this, when to do this, being safe to do this. And I think that is kind of where we're at. Any questions about anything? Did I go too fast? Good.
I have a question. Can you talk a little bit more about lifting agents, why we use them, and then just kind of the different layers and how that, yeah.
So we use two different types of lifting agents here at UC Health. We do have an Everlift. I don't know what company that comes from, but it's already got glue in it. And sometimes we'll even add like a half a cc of epi to it for lifting to help with bleeding. We also have Endoclot. That's where it's a higher viscous or kind of like a potato starch. And it comes in a dried powder. You mix a little bit of saline in there. We'll add a couple of drops of meth blue, but we'll also add epi to that as well. So this way you're having more of a sustained lift on that polyp to buy you some time. Yes.
I know the answer, but do you ever run into situations where you and the doctors have decided that you're going to go through to follow through and resect this, and then you've had to stop and you weren't able to resect? What are the reasons maybe you've had to stop?
Yeah, absolutely. This is definitely one of those situations where it could be a couple of reasons. Is this invasive? You know, you look at the polyp, there might be ulcer, but is that an ulcer from maybe a previous biopsy from their screening colon? Or is this deeper invasion into the muscularis? And if it's not lifting, maybe we shouldn't touch it with a CMR. Maybe they need an ESD. We have gotten into those situations where the pictures, they look fine, looks removable. We've gotten the pathology. It's only high-grade dysplasia. Where did they biopsy on that polyp? They go to the center? Did they go to the edge? They go behind it? That dysplasia goes from high grade to cancer, and it kind of goes in the center, but that also doesn't give you a read. Pathology is a little rough. You know, you get these cells in there, and it may be inflammatory, and it's hard to tell the difference sometimes between inflammatory and adeno. So we just want to make sure that as we're lifting that, oh God, I'm going to probably talk really loud. As we're lifting, we're making sure that we're looking at the whole polyp. Again, this is coming with the assessment. I will always chime in to my physician and say, it's not lifting over there. What are you thinking? Again, it's not up to me how we take that polyp out or when to take that out, but it is my job to say, are we sure about this? Because this is what I care about. I care about our patients and their safety. I don't want to cut something and then all of a sudden we now have a perforation. Polyp's still there. Now we still have a perforation. Now they're getting surgery. And I would like to prevent that at all costs. Hi.
Hi, Marcy.
Hi, Jen. We've spoken a lot over the years.
You guys are so great, so I'm grateful that we have you as a resource. So you hit on a little bit getting an EMR. You got the pictures, turns into an ESD. Before the case, what goes into deciding case lengths? Is that a navigator? Is that a doctor? How does that function?
Yeah, that usually comes from our providers. So what we utilize here is just like a little cheat sheet. It's called like a high-tech worksheet. It's just a little communication tool between the provider and the staff that are doing the procedure. They'll usually do that at the clinic level. Or they'll tell their navigator, like, hey, I'm going to need 3 hours for this. I'm going to need 6 hours. We've done them for 8 hours. So they're going to need a little bit more time. So it's kind of all through the process. Now I get that referral in, I'm looking at it, I'm like, okay, it looks like a 2-hour one. So in my mind, I'm already prepping myself how to prepare the patient. After they're seen in clinic, it might change and like, oh yeah, we're gonna need 3. So that's fine. That's no problem. So fortunately, it's not up to me, but the hard part is when we do get in there, we only book for 2 hours and it's gonna take us 4. Everyone will now be delayed and we're not gonna rush. That's not fair to anyone.
Awesome. Thank you.
Mm-hmm. Yes.
Can you explain the difference between a CMR, EMR, and ESD?
So CMR, EMR, ESD. CMR is a colonoscopy, like mucosal resection. EMR is just endoscopic. They're kind of used interchangeable, but endoscopic, I think, more like the upper part. And then ESD is endoscopic submucosal dissection. So that's where we're doing the layers of the polyp and we're tunneling underneath, almost like a poem if you've ever seen one. And we're wanting to stay a little bit closer to the polyp and less close to the muscle. Again, we want to avoid the muscle to avoid any perforation. Mm-hmm.
With EMRs, your snare. Did everyone hear that? So I was just pointing out that the tools are very different for an EMR, CMR, as opposed to an ESD, because the ESD, you're more using a knife and slowly like dissecting under it, whereas with EMR, you're just taking a snare and kind of grasping the whole thing and pulling it off.
And also your Irby settings are going to be completely different. You could be using like an Irby jet where you're constantly able to flush and lift in there. And we may be switching out between endoclot and just saline. Just depends at what it needs at that area. The edges tend to be pretty safe. We're getting good lift and then all of a sudden we start tunneling for that ESD. Now we're running into more scar issues. So now you're looking at, okay, we might need more lift, the endoclot lift versus just the saline. Using a cap to be able to pull stuff up. There's also some products on the market to create like a tension, to kind of lift that polyp up and create more of that space. Anything else? All right, well, thank you. I hope you guys enjoy the rest of this course.
All right, thanks everybody. We're going to take a short break before the next live case. So if everybody, you can get up, stretch your legs. If you need the restroom, it's outside the door to the left. Please be back there around 9:30 or by 9:30. Welcome back, everybody. There's that saying that healthcare professionals make plans and God laughs. So we're going to pivot a little bit. Our live cases are, they're live cases. We all work in the healthcare setting, so things move around a bit and we're just a bit delayed. So we're going to jump ahead a little bit on our agenda, and Carrie and Amy are going to give their talk on endoscopic myotomy. So I'd like to invite them both up. Both Carrie and Amy are interventional nurses in our lab here at UC Health. And both of them were my preceptors when I started here. So they're responsible for this. Okay, I'll come up. Come on up. Do you want a walking mic? No, I just have.
All right. Thanks for coming today, guys. I just wanted to introduce myself. I'm Amy. I've been in GI since about 2020. Before that, my nursing career was all medical ICU. I love the GI lab. I love how in-depth you can get with stuff and keep learning every day.
Same. I'm Carrie. I know most of you. I was been in GI for 9.5 years. I trained most of the nurses that are in interventional because I'm the oldest besides Marcy. Before that, I was in emergency medicine for 15 years. I knew nothing about GI. So when they offered me the position and I accepted, I had to go home and do a lot of Googling because I didn't know what any of this was. And then the more I learned, and I still learn every day, luckily I fell in love with it and our doctors and our team. And luckily the presentation we're going to give is one of my favorite procedures. I first started with Mahir Wag. Some of you may know, or at least know his name. And he kind of is the one that started this, at least at our facility. And we have continued it with other doctors like Hazem Hamad, and now we have Mohammed Bilal. So this was one of my favorites, so I'm glad that we get to present this to you guys.
Feel free to ask questions, make comments, or one-up us if you feel like you know the information well. We know there's a lot of smart people here. Do people at least know what poems are? Okay. Is there anyone who's assisted in a poem? I know. Okay. Lots of people. And then I'm sure there's people who have pre-op and recovered poem patients. So we've got a lot of different people in this room. Good. Well, at least you guys somewhat understand poems, but we're going to dive in pretty deep into how they work and our role as nurses.
We have to change that.
Yep.
I don't know how to do
Okay.
that.
All right.
Sorry,
you got
guys.
this.
I'm not very good at this, so, especially these slides and things. That's just not what I do. So we're going to go over, understand the pathophysiology of achalasia, understand the poem procedure, talk about what we should do pre, intra, and post procedure. We're going to go over some complications and how we respond to said complications.
All right. So some people say achalasia, others say achalasia, and some people who are fancy like me, achalasia. I'm just kidding. All right. Before we dive into poems, I want everyone to have a really deep understanding of what achalasia looks like. This is what poems are aimed at treating. So basically, it's poems arch nemesis. It's a rare esophageal motility disorder of the smooth muscles. The incidence is 1 case per 100,000 of the general population. It's basically a loss of peristalsis plus a failure of the lower esophageal sphincter to relax. So we're going to refer to the lower esophageal sphincter as the LES from here on out. Just as a reminder for people, peristalsis is the involuntary contraction and relaxation of the longitudinal and circular muscles throughout the digestive tract. It's basically what moves your food forward. For those nerdy nurses who want more of an explanation of achalasia, and I know there's some nerdy nurses in here because you're here, it's caused by a degeneration of the myenteric plexus and vagus nerve fibers of the LES. Achalasia is actually a Greek term, literally meaning non-relaxing. Makes me want to tell the LES to chill out, bro. So some of the symptoms of achalasia are dysphagia, both solids and liquids, food sticking, weight loss, chest pain, and regurgitation. With longstanding disease, the esophagus becomes tortuous and dilated and unable to pass food through. Up here, you'll see this cross section of the esophagus. I wanted you guys to understand these longitudinal versus circular muscles because if you saw my tunnel from the first slide, we're going to be eventually tunneling between these in order to do a myotomy. And then to the right of that, you can see what peristalsis is with a food bolus that causes the circular muscles to contract and then move the food along all throughout the digestive tract. So achalasia is diagnosed using a combination of exams. It's typically diagnosed around the age of 25 to 60 years old. One of the types it can be diagnosed with endoscopy. So what you'll see is a tortuous and dilated esophagus as you go down. You might see food and liquid residue and a narrowed or hypertonic LES that may be hard for the proceduralist to push the scope through. Can also be diagnosed with contrast esophagram or barium swallow. This will show a twisted and dilated esophagus. So that's the picture that you see up here. And then finally, the gold standard for achalasia diagnosis is esophageal manometry. It's a catheter that's placed with pressure sensors on it, that's placed past the GEJ. The patient then performs a series of wet swallows and the pressures are measured. We have specific motility nurses that perform these, so I don't personally see them performed much. But basically, it gives us this fancy color-coded graph to help us categorize achalasia. So the cool colors are showing low pressures, and the warm colors are showing high pressures. So it's essentially a heat map with time horizontally and distance along the esophagus vertically. And like I said, this helps us categorize, which is really important in deciding therapy. So Chicago classification is what we'll use. We're diving a little bit deeper into achalasia again, because I know you nerds out there may want to know. It's 3 categories using this classification. It's a fancy chart, but basically type 1, the food relies on gravity to travel down the esophagus. So it's basically just a big tube with no contractions happening. Type 2, the esophagus contracts in sort of a chaotic manner, uncoordinated, causing pressure to build up. And then type 3, it's more of a spastic, disorganized, more like spasms, you can think of it. The gold standard for this is POEMS because we can do a really long myotomy. Type 2 and type 3 have shown the best response to endoscopic myotomy therapy, which you're going to learn about shortly. But first, I want to talk about some other treatments before we dive into POEMS. Of course, we always have to talk about lifestyle modifications. So eating slowly, taking smaller bites of your food, chewing thoroughly. These are all things that can help food pass down the esophagus easier when you have achalasia. Drinking lots of water, avoiding solids 3 to 4 hours before bed, elevating your head of bed. And then medications. So that's going to be your nitrates and your calcium channel blockers. These are going to lower the pressure, basically relax the LES. And then dilation, Botox injections will do. And then Heller myotomy. So this is a laparoscopic form of myotomy. And then finally, POEMS, which I'm going to pass off to Carrie to dive into talking about why we're here. Okay.
All right, a poem. So some of you have said that you've been assisting in them. We have nurses even here that have pre-opt and recovered, but you may not still really know what a poem is. I did not. I think that's when me and Mahir Wag kind of became soulmates when it came to poems, because he kind of had to break it down even for me, because when you talk about it, it doesn't really make sense until you see it. But a POEM is a minimally invasive endoscopic procedure. The oral began in like the 80s. Tunneling started in like 2007. When I first started doing this, the POEMs that we would do were new to us. So it took sometimes 3 and 4 hours. And then as time went on, and obviously they got better and felt more confident in themselves of performing the procedure, it took an hour, maybe hour and a half. But there are three different kinds of poems that we do at least. The traditional esophageal poem, there's a Z poem, which is a Zinkers, which we'll get into. And then a G poem is a gastric poem. Let me do all that. Oh, good Lord. Sorry, like I said, I'm not really good at this. I get very nervous doing this. I kind of want to just hand this to you and say, here, but I won't because this is what you guys are here for. So I apologize.
We're better nurses than we are speakers.
Yes, much better,
And
actually.
Marcy's at the bar high, so we're mad at her.
Yes, she was very relaxed and I am very not at all. A couple benefits of the poem over heliromotomy. It's incision free, shorter recovery time. We can treat a different wide segment of the classifications that Amy described. It works well for type 3. The downside to a poem is that it can cause more GERD because now it's open, so you're going to get some more reflux. So like Amy said, there still are like some risks and things that are going to happen after said procedures that we need to know about because that's what we do as our nurse role. So we just need to make sure we prepare the patient for what could happen, what can not happen. You're not going to get cured immediately. But with a poem, it is better than, like she said, a heliromotomy. And that's that one. Thanks for keeping me through this, Amy. Poems there are minimal risks, but there are only a few things of reasons why people shouldn't get a poem. Some people can't tolerate anesthesia for whatever reason. People that are on blood thinners and they can't be held. Marcy did also mention like with ESDs and EMRs, because we are cutting into vessels, whether it be a small vessel or not, it could bleed. And if they're on blood thinners, obviously, and can't get off, that will make it worse, a higher risk. And some people don't want to be on long-term PPI. I myself am not a good medicine taker, so I also probably wouldn't want to be on that as well, but so I understand that. So just a few, I mean, so it's not really, so, it kind of applies to everyone, really. Now pre-procedure. I really should have brought my glasses too. Sorry, guys.
Sorry, can't help you with that.
I know. Thank you. Actually, one of the things that I found interesting, which I guess I didn't know, for pre-procedure education, we wanted to make sure we tell our patients that they can't travel for like at least like 3 or 4 weeks post-procedure. Because, and at first I kind of didn't, I was like, what? That doesn't really make a whole lot of sense. Because if they go, let's say they're on a cruise, we did have a gentleman who was scheduled for a poem and in a few days was going to go on a cruise. Well, what if you have a complication in the middle of the ocean somewhere? Other places may not know what a poem is. They won't know what was done, how to fix it, if they start bleeding. So I honestly didn't, I guess, think of that. I thought maybe for a few days, but it takes time for that incision, even though we close it, it takes time for that to heal. We also need to make sure, like even Marcy said, cessation of blood thinners, and the new GLP-1s. We want them to not take those. I think it's for about 2 weeks prior. Our doctors also will prescribe an antifungal because they haven't been able to swallow for a while. They may have some candida. If they do, when we first start the procedure, we take a look. If they have candida, then we can't do the procedure, or lots of food, we can't do the procedure. So usually for 2 days, they can only have clears. They need to have only Sprite and water. The carbonation of the Sprite kind of also helps with the candida and getting rid of any maybe residual food. Day of procedure, obviously NPO. And usually our patients will be admitted overnight because they're going to have an esophagram the next morning to make sure there's no perforations, and then they'll be discharged. And the risks, did mention the bleeding already. Obviously, we can perforate because you are dealing with such, I guess, a tiny tube and tiny muscles and tiny vessels. So one small nick we can have a perforation. So again, kind of bringing Marcy's into ours. With a perforation, you also need to make sure you have the tools in the room to fix whatever may happen, whether it be bleeding, perforation. Again, the GERD the patient may have, so when you let them know, they could get an infection during the procedure. They do get antibiotics. I think they do get post antibiotics. We always check the patient because we are laying on CO2 the entire time through the procedure to help open our incision. So there is a risk of a pneumothorax or a pneumomediastinum. Oh, that's you. Thank God.
Good job, Karen. So I just wanted to make note about, I'm going to talk about the setup and equipment that we need. This is specifically how our lab does things. I'm sure there's a wide variation of these things based off of what the proceduralist wants, the patient themselves, if there's complications or comorbidities with the patient. So getting into it. So of course we need a gastroscope or an EGD scope with a distal attachment cap. So on Marcy's videos, you saw that kind of clear cap on the end. So we always want one of those. We need an Irby with a grounding pad, of course, because we're going to be cutting. And then some sort of knife. So some proceduralists use the same knife for the tunneling and then the myotomy, and then others will use one type of knife for the tunneling and another type for the myotomy. An injection needle, a cautery device. I'm sure there's lots of used, but we use specifically a coag grasper. Clips or suturing, and I'll kind of talk about why you'd want to use one or the other. CO2 insufflation, you have to have low or ultra low settings on that. So like when I started, we had to have different type of tubing, but now it's just a button and we can switch it to low and ultra low. And you're going to be helping with that a lot because the doctor is so into this procedure, they might forget. And so as soon as we're going into this little tiny tunnel, make sure you're talking with them like, do you want ultra low? And then the patient needs to be in a supine positioning with just their head tilted towards the proceduralist. I wanted to make note that we open as little as possible at the start of the procedure, only what we need to first do the inspection, because as I'll be talking about shortly, there's a lot of reasons why we may have to abort and not do the procedure. So we'll talk about those things shortly. So we don't want to open everything and then have to throw it out because this is some really expensive equipment we've got. So like I said, other doctors and facilities may have different preferences and actual capabilities of what they can do. So keep this in mind. And then I also wanted to talk about when I started, it was so overwhelming with all the equipment we needed. I couldn't, and my memory is not the best. So I could never remember every little thing we needed. And I felt like I would forget something, and you really don't want to forget something because you look dumb. You're like, they're like, where's this? And you're like, hold on, let me go grab that. Or you ask your backup partner to go grab it for you. And it's just, it kind of messes up the flow and their trust in you. So I would do the whole setup, take a picture, or I'd have like my preceptor do the setup, take a picture. And then every time I had to go set up for a poem, I would refer back to my picture. It's funny though, because things change so quickly here. I look back at that picture and it's all different. The tools we use are different. The tubing we use is different for the CO2. So, but I think it's a great way to not feel overwhelmed with these procedures. Because again, half of our job as interventional nurses is just knowing equipment and tools and grabbing the right things at the right time. So it's a fairly simple procedure when divided up into steps. So first is inspection, second is injection, and it's sort of like what Marcy was talking about, like we're injecting to get this lift. 3, mucosotomy or incision. 4, tunneling. 5, myotomy, and then 6, mucosal closure. So inspection is super, super important here. The doctor will inspect the esophagus before deciding whether or not the procedure can be performed safely. So the doctor confirms that they're free of yeast, and this is why pre-procedure, they may have been instructed to take like a nystatin or something. Free of food, stasis esophagitis, ulcers, or any other unforeseen condition that may impede the doctor's ability to perform this safely. Since we're cutting into the mucosa, it's got to be clean and looking great. At this time, the doctor will request that the patient be paralyzed and given antibiotics. So this means that it's a go. So we're able to, as nurses, call out to the PACU and say, hey, set this patient up for an esophagram and get them a bed because we're doing the procedure. Most proceduralists require that the patient be admitted after the procedure with strict NPO status, no NG-OG tubes, and a scheduled esophagram. One of our previous providers actually was able to discharge same day. So they'd go straight after the procedure, get an esophagram. As long as there's no tears or perforations or anything else, they were actually able to go home that day. So depends on the provider's preferences, depends on the patient's comorbidities and all that. With the patient in supine positioning, those in the room, including the nurses and the doctors, should feel the abdomen and the neck to check for softness. And you just want a baseline of where they feel, because once you start cutting and putting insufflation in, you're going to really want to be checking that the stomach remains soft and that the neck remains free of crepitus. If you do feel, say, every 5 minutes you're checking, you feel a really firm belly, or you feel like bubbles in the neck, you're going to want to tell doctor, anesthesia, everyone in the room, like, are we either using too much or is this a perforation or a tear? It's really important at this point to have good communication with anesthesia. If they notice an increase, so we're going to tell them at the beginning, let us know if you notice an increase in the CO2 of the patient or a sudden rise in peak pressures, because this means a lot for us. Like, we will probably have to stop the procedure or just suck a lot of the insufflation out. So this procedure is really a communication between doctor, nurse, and anesthesia to make sure everything's safe and we can keep going. Like I said, now you can let them know that it's a go, let the PACU know, so they can request a bed and all that. And then one more thing before we dive into cutting and all that, we like to have a little Post-it note for the doctor stating the time that we inject, cut, start tunneling, end tunneling, start myotomy, end myotomy, and then closure and how many clips we use. I'll hand it back to Carrie.
Wow, they are getting really rowdy over there.
I know, they are loud.
Does the video work? Yeah. I like how cute is that? Okay, just making sure. Again, we're not good at this, so we're just making sure. We're just making sure things are working. So like Amy said, the setup was easy. Now we're on to the injection site. Oh, no, this is the injection.
Increase the time.
It's true.
Yeah.
You're like Marcy did.
Exactly.
Sweet. So that's the lift with the meth blue and saline, just to give us a bleb to bring up the mucosa so we can cut safely. We cut into the mucosa and then he'll start the tunneling, which will be a video momentarily. Like I said, we just use meth blue and saline. And again, I think Marcy's talking hours. Probably should have been all at the same time. Because like she said, the meth blue helps separate the layers and differentiates the muscles. And in a moment, we'll see once we inject the different layers of muscles that we can cut. You want to cut the circular, not the longitudinal. Is that right? Yes. Another video.
Oh, this is still injection.
Oh, it didn't move?
Okay, here's incision. So are you still on?
No,
Yeah.
we're on
Okay.
this one.
So here's the incision.
Incision. And like I said, every place has different tools and devices and needles. Is the hybrid T knife that we use. It's from Kirby. It is the needle of preference. It takes, colorize, and cuts. And with the settings that we have, again, every different facility makes different settings, different tools. This is just more facility. So first, place the incision. It's usually about 1.5 to 2 centimeters in length. It's just enough to let the scope go in. Manually to the tummy. So this portion of the procedure involves dissection. You'll notice like this is our tunnel right now that we've created. So this is when it gets really, really key because it's really delicate dissection. This is when you want your CO2 down to low, ultra low. Is to be super so move to coagulate this vessel. If you do hit one and it bleeds, this really affects the visualization for the proceduralist. It's that blue, right? Blue, this all right. Make sure you change the settings to self. Proceduralist usually means you, but you really want to be reminding them because they have so much to think about. So it's really good to be on it with the Kirby device or whatever you may use. Again, I want to talk about this is a team approach. The procedure, the doctor will need the best visualization and concentration throughout this procedure. Because it's these tiny little movements and tiny little vessels that you might not see. So I can't stress enough how creating an organized, safe environment for the proceduralist is really what's best for the patient. That's what I'm all here for. Having tools on hand and not having to run out and grab something helps improve patient outcomes. Every second is important with these procedures. So just really keep able to predict the next step too. So you see that big vessel, have that call out when you see a vessel or when the knife is too close to us. Get to be a season. And then the tunnel's complete once it's about 2 to 3 centimeters into the gastric cardia. This can usually be visualized by coming back out of the tunnel, going back through the normal lumen of the esophagus, and you can sort of follow like a rug
blue discoloration, and you can see how long you've gotten. So once you're 2 to 3 centimeters into the gastric, we can.
Okay.
Is what's going to help open up esophagus and lets things open and smooth out. Like Amy said, make the LES chill out. I'm going to finish.
Oh, that was loud. Sorry.
Who's out there? So this is a really good picture of that you can notice. And as we're doing this, this is the time to make sure if the doctor wants to use the same knife and tool. We do have other knives that have an insulated tip. This is not the one, this is the one that we use most commonly, but there are different types. We do have one that has an insulated tip so that it only protects the muscle, so you're only cutting what you're touching with that knife. It's the end, as Amy said, as on me until it's done. And we'll come back out. As you've injected the whole way down, the outside, the normal lumen of the esophagus will be blue. And once we get down to where they think the stricture is ended, then we know that we are done, and we're going to make sure we evaluate the LES and the native lumen. Once it's inspected for bleeding, we would know by now if we have got everything under control. Then we can move on to the final step, which is the closure of this tunnel. You do it better. So it's going really fast, but you can see the incision there a little bit. In our case, most of the time for E-poems, as we call them, we do use clips to close this incision. This is where it's kind of important for the nurse or tech in the room to watch the closure, make sure that it is completely closed. The doctor may think he has put enough clips, and yes, it's good, but after reevaluation, it's good for all the communication in the room. If you see something like, oh, you may want to put one more clip there just to make sure. Because of the closure and the clips, that is when it's important for us to make sure that that is completed. And that's why it's also important for them to have no nausea. We don't want them to coma. We want to stay NPO. We don't want anything to hit those clips and open that back up. That part? Yeah. All right. So I did say there were other kinds of poems that we do. There's a Zinkers and then there's a gastric. For the Zinkers, if you don't know or haven't done this kind, it's like a diverticulum kind of in the esophagus. It's like an outpouching that forms, and it's an area of like weakness in the laryngopharynx. We target the muscles of the septum between the esophagus because it's like a little pouch, and sometimes food can get caught in there as well. So we want to open that up. So we'll cut the septum in between the pouch and the esophagus. It's been shown to have lower morbidity and mortality, lower versus a surgical treatment of the Zingers. It has a high rate of recurrence with symptoms recurring greater than 10% of patients, but it still at least gives them relief. There's also the gastric poem, the G poem that we do. And it more is for gastroparesis. Sometimes they have poor response. We make sure for like 6 months they've done the dietary modifications, taken their medications. But in these procedures, instead of the LES, the proceduralist will target the pyloric sphincter to relieve the symptoms of gastroparesis. The setup is the same. We're still going to check for crepitus in the neck for the Z poem and the G poem, but also the belly to make sure it doesn't get too distended. For all of the poems in the same, it's all pretty much the same setup. And our post-procedure. Our recovery nurses have obviously been doing this for a while. They hear a poem and they're like, okay, we know the drill. But for the patient, it's good for the recovery nurses post and pre for the patient to have had said information, that after the procedure, they're going to be in clear liquids for 3 days once they get discharged, and then full liquid for 3 days, and then a soft diet for the next 2 to 3 weeks. Then they can resume a normal diet after that to make sure, once they know they can swallow properly, they're going to still educate that they need to eat slowly, smaller bites of food, stay sitting up, drink plenty of water while you're eating. You may have some pain. They may have some chest pain. They're going to have some reflux, as we have discussed. So they're going to be on some medications for that. They're going to be on light activity. They need to get up and hopefully walk more so than hard activity, just to help the motility. They can drive, obviously, after the next day, and then as long as they're on any narcotics. 1 to 4 weeks, they can do normal activity. They can even have been back to work. The patient may come back for testing in about 6 months, and then potentially at 2 years and 5 years after the procedure. It's important for the nurse to help the patient understand that this may not fully eliminate their symptoms. It does help open up and help them swallow, but they still are going to have to know that it may not completely help them. And again, the reflux may maybe get worse for them that they haven't noticed before, because now it's opened up and you're going to see almost like the stent that we saw earlier in Wani's procedure. That stent opened it up and you saw some of the gastric contents coming up because it hadn't been opened before.
All right. So we found an article. Since poems have been around for about a decade and a half, a little bit more now, there are more studies now about the long-term effects. Originally, of course, it was all short-term stuff, but a 2020 report from a Chinese medical journal found that the long-term outcomes of treating achalasia with poem are satisfactory, with an 88% treatment success rate after a follow-up of 7 years or more post-surgery. This treatment success rate, they also found, is comparable to the Heller laparoscopic myotomy. So this is awesome for poems. This study found that a rate of 38% for clinically adverse reflux events. So again, it's going to happen. Because of this, the study also summarized at the end a set of post-poem recommendations. And this was actually from patients with achalasia who have undergone the poem procedure. So they summarized what they basically said people need to do, which is 1, alternate between eating and drinking water when consuming dry food, walk for 10 to 30 minutes following dinner, allow at least 4 hours between dinner and falling asleep, and then avoid chili peppers, seafood, and liquor. That's kind of a bummer. Once again, it's good to set realistic expectations for your patients and provide lots of pre and post procedure education. Again, you're not getting your peristalsis back. We're giving you a tube that now the food can get through. So that comes with, understanding you're not getting a brand new esophagus. And then finally is Bilal here?
Do it. Hey, Dr. Wani.
Or maybe he's doing stuff.
Is Bilal coming?
He's busy. Okay.
Does that one want to do it?
Well, we wanted our favorite poem doctor to come actually read a poem written by AI about poems, but
And it's a very
and he loves the poem.
And he does love the poem. He's our now resident. Our other doctors that did do poems have left,
Yeah.
and went to other facilities. So when we showed him this poem and he was reading it out loud, it was it was almost like Shakespearean.
Yeah.
So we wanted to have a special guest come read this for you, but if he's unavailable, we can read it. Are they getting him? I'm sorry for the delay, but I just want you.
Okay.
Okay.
So,
Anyway,
here he is.
Yay! So special presenter is our resident poem
Our
physician.
poem
Our poem
brainiac.
specialist.
All right, here's your poem.
Here's your poem.
Perfect. Hey.
This is Muhammad.
Bilal, everybody.
These two. 1, 2.
All right, awesome.
There.
They've done all the fun part and left this embarrassing part to me. Well, first, I just want to acknowledge you all for being here, and thank you for supporting the course. And obviously, this is only possible. All the work we do is possible with our nurses, and we truly have fortunate to work with all of them. Even though I may have the scope in my hand, but the reason the procedure is successful is because of our nursing team. So thank you to all of you guys and all of the ones who are attending for doing that. Also, shout out to two of my Minnesota nurses who were there for my very first poem when I did. So it's good to see you guys here as well, and welcome. That was about 3 years ago. Yeah, so yeah. All right, so I have to read this poem. Dr. Wani is gonna be looking at it. So, Echinaceia's grip, a cruel disease. The esophagus tight, no food at ease. A struggle to swallow, a battle to sup. But hope arrives a gentle new way. Poem is here to brighten the day. No long cuts, no scars to recall. A camera guides with instruments so small. Through the esophageal lining beyond the wall, a tunnel is formed with skill and grace. To find the clenched muscles in their hiding place. With precision, the fibers are gently cut free. The lower sphincter yields, setting the passage free. No longer constricted, the path is now clear. Food and drink flow freely, dispelling all fear. A swift recovery, no lengthy stay. Back to life's rhythm each passing day. The joy of eating, a simple delight. Return to the body, a welcomed new right. Home, a marvel, a gentle release. From Echinaceia's burden, bringing welcome peace. A testament to skill, a testament to care. A renewed life for those who were snared. So thank you, everybody. And thank you, Amy and Karen. Yes, thank you for all your work.
Thanks for coming.
Thanks for coming. And that is our conclusion.
All right, guys. They're ready for us in the live case. So if you do have poem questions, we'll be happy to answer them. But I think we're gonna switch over to the live case just because patient's asleep and we're ready. For moderation for this case, we have Dr. Sachinwani and you right here, and then myself.
Where'd it go?
Okay, I'll go over the case presentation. This patient is a 52-year-old female who underwent screening colonoscopy. She has no family history of colorectal cancer or adenomas and was found to have a 3-centimeter sessile polyp at the hepatic flexure. Attempted a lift, which was unsuccessful. The area was tattooed, and the patient was referred to our center for endoscopic mucosal resection of this hepatic flexure polyp. And we have one of our most skilled endoscopists, Dr. Muthing, who will be demonstrating endoscopic mucosal resection. And this is what the polyp looks like. Again, an hepatic flexure polyp. I'm sure Larissa is going to describe the appearance on her live endoscopy. We're okay to go live? Hi, Larissa.
Give us a little.
Larissa, can you hear us?
I'm not hearing them in here. Yeah. Yes, I can hear you.
Oh, fantastic. How are you doing, Larissa? You're live?
I'm doing good. How are all of you guys doing? Thank you for being here.
We're doing great, Larissa. tell us what you're doing, where you are, and if you can describe that polyp to us.
Yeah, so we have about a 25 to 30 millimeter sessile polyp here right at the hepatic flexure. Our referring endoscopist did a really nice job of tattooing for us. You can see the tattoo right adjacent to the polyp, but not involving the polyp at all, which is very helpful.
Larissa, can you, I think this is such an important point you just made about the tattoo. Can you speak a little bit more about the general principles and guidelines on endoscopists who are going to tattoo the location of the polyp? What should folks be doing?
Yeah, so definitely a tattoo can be helpful for us finding more subtle polyps. And this is a tricky polyp kind of between folds. Definitely a good find by the referring endoscopist. And so a tattoo can be really helpful for us in identifying it as we approach resection. But tattoos do cause fibrosis in the submucosa. So if the tattoo is placed directly under the polyp, that can be a hindrance as we start to resect and can make it more challenging. So we like tattoos that are on the opposite wall as this one is, and potentially, at least a fold or two distal or proximal to the polyp, just well documented where it is, to help us identify but not get in the way at all of our resection.
That's great. And Larissa, perfect. You're going to show us what the polyp looks like.
We'll look at the polyp here under narrowband imaging. We're really looking at the mucosal pit pattern here, which we can see is nice and regular, not seeing any particular areas of concern. They did
Larissa, what would
biopsy this
that look
polyp
like
and it
if
came
you
back
were?
as tubular adenoma.
Yeah.
And this is fitting, we have classifications that we look at. So this would fit nicely into a NICE 2 classification and a Kudo 3 classification in here. So very amenable for endoscopic resection and very amenable for EMR.
Could you describe that just more as well in kind of a visual? We just a lot of our audience members don't necessarily work in interventional settings. So as far as like visual things that you're seeing, what would you be looking for that would be concerning? Like, as far as like what the pattern looks like. Does that make sense?
Yeah, as Larissa is getting situated, I think this is such an important question. What are the characteristics of a polyp that may be malignant in nature? So you're essentially looking for that loss of mucosal or vascular pattern that you are appreciating in an adenoma, distorted vascular pattern, areas of depression within the polyp. So these are just some characteristics that we as endoscopists look at to try and predict whether this polyp is more than just an adenoma and may have some submucosally invasive cancer. And these are the different patterns that we look at. Larissa, can you still hear us okay?
Yeah, I can hear you just starting now.
Oh, perfect, perfect. So, Larissa, you're doing another important step here. I'm guessing you're getting ready for the submucosal lift, but you've done another maneuver that the nurses should understand. If you can just talk through that.
Yeah, so when I approach my lift, I really like to start my lift at the proximal edge of the polyp, and that really helps to bring the polyp distally and put it in a prime location for resection. and avoid kind of moving it more into those folds. So in order to best do that with this polyp, I retroflexed. So now that I'm at that proximal edge and able to kind of position that lift so that then this will bring it forward to help us resect. Potentially, we'll see how the lift goes and decide whether to resect either forward viewing or in retroflexion.
That sounds great, Larissa. We'll let you do your thing.
Needle out.
Needle out.
So Christy is the nurse that is teching this procedure. She is using a lifting agent called Endoclot. It's something that we mix here. It's a powder that we reconstitute with saline, and it forms kind of a thick gel. It is naturally clear, so we do add methylene blue to that. And then depending on provider preference, epi may or may not be added. This little syringe that she's using is really nice because it not only it helps your wrist when you're pushing, it makes it a lot easier on your hands. Each half twist is a half cc, so it's nice instead of constantly looking down and up and trying to communicate with your provider how much you're injecting. You can just tell them.
Stop. Yep, needle back.
Okay.
Go ahead. Yeah, Larissa, there are two questions for you. One is the choice of your scope, a regular colonoscope versus a PCF, and whether it's your standard practice to mark the polyp before you resect, especially given the fact that it's a flat polyp. Do you ever do that?
In terms of the choice of the scope, I base my choice of the scope on the patient's body habitus, potentially how much I think I'm going to be needing to do in retroflexion and polyp location. I like to use a regular scope to kind of minimize looping as much as possible so that I have as straight of a scope to approach resection. But if I think that it's going to be challenged with retroflexion, I will use a PEDS colonoscope. She, based on her report, had a, relatively straight colon without significant diverticular disease. So it felt like a regular scope was sufficient for her. And then in terms of marking the polyp, if I'm able to see good borders of the polyp, and I'm planning on lifting, which is going to aid in my visualization, I don't standardly mark it. But if I'm going to be more doing underwater without lifting, that would be when I would mark it. Needle out.
Okay, needle
I'm
out.
sure you guys are also noticing the fact that Larissa's got a distal attachment cap, which is something that we always use for a patient who is going to undergo resection.
2. Stop. Okay.
Christy, could you tell us a little bit about how you communicate with your providers when you're using an injection needle and how we do our best to keep everyone safe?
Yeah, so anytime she asks me to put the needle out, I make sure and let her know when the needle's out. In the instance she forgets to tell me needle back, anytime I see the needle come usually back into the cap or the scope, or if I see her lose her position, I'll usually just automatically put the needle in.
Needle back.
And that way she doesn't risk poking the patient's colon in any spot that she doesn't intend to poke.
Christy, what injection needle are you using?
This is the Olympus injection needle.
Yeah.
I'm actually not sure the full name of it. This
Needle
is the one
Master
that,
by Olympus.
Needle Master, that's right. This is the one that we tend to use the most over
Needle
here
out.
in interventional. Needle out.
Inject.
Okay, injecting.
I'm sure you guys appreciated the fact that Dr. Muting injected the polyp proximally in retroflexion. She got a decent submucosal lift, and now she's looking at the polyp on FOS and on, and now injecting the more distal portion of the polyp.
I've heard some of the doctors describe the dysplasia patterns as like roads. Do you know what I'm talking about? Can you explain that? Because that helped me a lot.
Yeah, and I think you heard me say that when I was describing the patterns even for Barrett's esophagus. So we do have cases lined up tomorrow where you'll get to see distorted patterns and normal patterns. Way back when I had started my training, one of my mentors told me that imagine if you were driving a car through all these different patterns that you are seeing, the mucosal patterns. If you're not able to see a clear path for you to drive on, then that's when you should be thinking that the pattern is distorted and this may be consistent with dysplasia. So the pattern is the NICE 3 classification pattern that is consistent with malignancy or consistent with submucosally invasive cancer. Larissa, are you happy with the lift?
Yeah, I think we got a really nice lift to start here. We may need to lift on the one edge a little more, but I think we're going to get started with this nice lift here. I'm opting to use a 10 snare. It's sometimes appealing to use a larger snare for these larger polyps, but based on how this polyp is, I think we're definitely going to need to approach this in a piecemeal place. And I think the smaller snare is going to give us more control and then ultimately also just safer for the patient. Open. Okay, opening.
And could you tell us a little bit about what type of snare this is, please?
So this is a braided stiff snare, which really helps us to grab onto the mucosa well for these flatter lesions. Close. Okay, closing. Okay, snug. All right. And then
Before you go ahead and cut, can you just tell us exactly what you told Christy once you got the snare around and what your next steps are?
yeah, so I want to make sure that my first cut, I have like nice margins to make sure I'm not starting in the middle of the polyp and approach this systematically. So when I liked my position over the snare, I asked Christy to start to close. Christy is an expert tech, and so was watching with me and kind of adjusting her closing speed based on how the polyp was going too.
Christy, do you want to comment on how quickly you close the snare, or how do you approach that step? Because this is such an important step for resections.
Right. So I just go slowly, like she said, just making sure that I'm watching as I close it. If I ever have any question about, oh, I don't think we got that side, or this doesn't quite look right, just because I have been doing this for a while, I'll communicate with her, oh, this doesn't feel right. I'm not sure I got that side, and then we can just kind of talk to each other and maybe reapproach it. And then I close the snare until I feel just snug on the polyp, and then let her kind of reassess, and then she'll decide if she wants me to close more, open to release a little bit, make sure we don't have any tissue we don't want, and then we'll continue from there.
Yeah. Now we're going to release this a little, so I'm going to have Christy open slowly.
Okay, opening.
And as she's doing that, I'm lifting away to kind of release any of those underlying muscle layers. I move my snare back and forth to help release that, and then have her close back down again.
Snug.
And then I'm going to have her start closing down slowly to the hub.
Okay.
But if I'm seeing that it's starting to cut, I'll have her stop, and then also Christy is huge in that and letting me know down.
Good. Yep.
And then here, I like a lot of feedback. from my nurse or tech of how that's feeling. We're having her tell me if it feels bouncy at all.
Oh, it feels good.
Okay. And then we're going to go through with EndoCut Q, and we're using our standard right colon settings here. So I'm using the yellow pedal to cut through this.
Let me take this.
Oh, you can get in.
Larissa, as you're getting that piece out of the way, that looks beautiful, by the way.
Yeah, and I do like to, move that piece out of the way and assess after each step and just make sure there doesn't appear to be any deeper injury that we want to know about right away so that we can deal with that.
And is your plan to continue to do this in retroflexion, or are you going to undo that to remove the remaining portion?
I think we'll see if we can do at least one more in retroflexion and then an approach, but we'll have to see. It's definitely a challenging location of this polyp.
agree.
So I think we're approaching it as we go right now. Open.
Okay, opening.
The good news is that you guys don't need to memorize the setting. All of these are smart cautery units, so these are all inbuilt within the unit. So you just need to find the right colon setting, and that takes you automatically to the setting that Dr. Muting and Christy are using.
And Christy was talking earlier about opening the snare slowly. This is where that gets to be extremely important, because if you pop open a snare and the patient coughs or sneezes and you are flicking out your snare super fast, you can snare right into the polyp or right into a vessel and cause a perforation.
So what you can see is that she's got the snare around the polyp, and then she's using suction to get the polyp within the snare.
Okay, snug.
And then she's looking for feedback from Christy.
How much?
All right, let's open up a little bit here. Okay. We're going to release again here and close down.
This might go cold.
Yeah. Yeah. And then we can just tell based on how superficial this is and kind of how Christy is feeling that if we close down any more, that's going to cut through this. For coagulation purposes, we do want to have some cautery as we cut through this. And so we're going to stop here and then go ahead and cut through that. And then we'll switch back to forward viewing and see where we're at.
Larissa, this is looking really good. I have a question for you. Obviously, there's been a lot of progress made in this field of resection. When do you choose to not inject and resect, or when do you choose to do underwater EMR, or when do you do lift and just do cold resection?
Yeah, and I think a lot of this depends on we don't yet, although hopefully sometime soon we'll have more randomized controlled data on this. Let's actually do a little more lift. So I think a lot of it is based on provider preference. We have some evidence that shows that using snare with cautery lowers the risk of recurrence of the polyp. So especially if I'm approaching an adenoma and I think it's very safe to do snare with cautery, that is my preference. Just, we're here, we want to, as best as possible, remove all of this polyp. And then when we come back,
have there be nothing left. But if there's ever a question of location or just based on patients' risk factors where I think it's a little riskier to do, cold EMR is a great option. And then definitely think about underwater for flat lesions or those that are even more challenging to lift. It can be really beneficial in those. Needle out. The one place I think where we have really great data is in our sessile serrated lesions, where the data shows that cold resection inject is really good for those, and we don't need to think about hot EMR for that. Stop.
Okay.
Another thing as far as injection goes, depending on where the polyp is, how much it's been worked on or not worked on, the submucosa can become sclerosed, and so sometimes you don't get as effective as an injection. Also, there's we're jabbing into random things that we can't see behind. So sometimes you can go through the polyp to the other side. Sometimes the needle can go in a little too deep. It's not harmful to the patient, but you're not going to get that lift in the submucosa. So as the tech, it's really important to communicate with your provider. If it feels like super easy to inject, it might be spilling out to the other side. Or if it's super difficult to inject, you could be injecting into a mass that is invading the muscle layer. So it's always good to give that feedback to your endoscopist.
Okay, needle back. All right, let me take this. Take it. Yeah. We can see up in this corner here that it's not lifting quite as well there. This may be due to some scarring from biopsy or just kind of natural scar fibrosis that can occur with these polyps. So that's kind of an example of what we might see too when there have been prior resection attempts and or tattoo underneath the lesion. That's also kind of where our tattoo is approaching, just the kind of the edge of the lesion there. Dr. Wani, I'd be curious your input. I think sometimes the biopsy of the lesion is helpful in kind of helping us to know what we're getting into. But I know there is some concern with scarring for that. What is your take on our referring providers biopsying these lesions open?
Yeah, I think that's such an important topic for discussion. I think the message should be that you should not take on a polyp if you don't think you can take it from the start to the finish, and especially not to use any cautery within the polyp, because that's what makes the polyp even harder for us to resect. And Dr. Muting already talked about the harms of injecting a tattoo into the polyp or really close to the polyp. I'm okay if the referring endoscopist takes a biopsy or two, especially if they're concerned that there might be malignancy or high-grade dysplasia. That really does not bother me. What bothers me is if they've resected half of the polyp and now referred the patient to us for resection. Not that we can't tackle those polyps, it just makes it a little more challenging where we have to use other techniques to take care of the polyp.
I think
And
it's
then you can
worth
see
noting.
here, there's a little bit of oozing with these. If it started significantly oozing, that would be something I'd be more likely to treat. Close. We did not use any epinephrine in our injection. Open up just a little bit. And then close down to your snug.
Snug.
Keep closing a little bit. Okay. Over there. All right. I tend to not use epinephrine because it can cause some pain for the patient post-procedure. But I'm curious for others if what their practice is using epinephrine in their lifts.
I agree with you, Larissa. I don't use epinephrine either in my injectate.
But this was such a beautiful example of using your cap, suction, and the amazing job that Christy is doing in terms of how quickly she's closing the snare. It was just really beautiful to see.
Yeah, and I can't give Christy enough credit, and it's really truly incredible to work with nurses like Christy. And so much of this is communication, but when you work with somebody like Christy, that communication is almost like instinctual too. Close.
Okay, closing.
I
So
will
I think,
admit to this. I think they can read my mind.
yeah, exactly. I
The
think
nurses
Christy's
can,
always,
and they know
yeah.
exactly what I'm thinking. And this is why we enjoy what we do, because we work in this environment where we have this amazing understanding. They can actually predict our next move, or we just communicate so beautifully. So this is just like poetry in motion. This is really amazing.
Okay, go.
Amy, did you have something you were gonna?
I was just gonna say, I think
Release a
it's
little bit. Okay.
worthy to note Christy's little towel down there, because I did some travel nursing and
Okay,
I had never seen this anywhere else. And it's such a simple step, but it keeps things organized. So we like quadruple fold a towel, and then between each layer, we put all of our different tools. So did you see how quickly they switched out snares and injection needle? She's not having to like untangle things, and it's just really smooth. So it's a great thing to take back to your lab if you're interested.
So Larissa, I think there was just like that one piece there, right?
Yeah.
Was there anything else that you were going to go
There's
after?
this little piece here, and then I think there's a little bit left in that area that's a little more scarred. I may actually think about taking that area cold, just kind of based on how that scar is kind of running into as we slip over the edge here. And then I think a little bit left in this corner here. But the polyp is mostly gone now, which is great. Open?
Okay.
Of course, please. Right here.
Close. Okay, close.
Can you speak to just strategy, kind of decision making about what would make you want to take this off in one piece versus piecemeal?
Larissa, I don't know if you heard that question.
Yeah. Close, please.
Decision between en bloc versus piecemeal.
Yeah, I think, if we are able to safely take it on block, open up one more time.
Okay.
A little bit. Close.
Close.
That is always my preference. With this polyp, kind of how it was spreading, given the size of it too, really in EMR, the largest snare I'm going to standardly use is a 20 millimeter. And even with a 20 millimeter, I think it would have been challenging to get this polyp on block. Let's switch to an X-Acto.
Okay.
And so, and then, and so, from a safety standpoint, I think was better to approach it for piecemeal. The other thing I'm taking into account is that assessment of the polyp. So for her, the polyp had that nice regular pattern. Based on our assessment, we're thinking this is going to be precancerous, likely a tubular adenoma. It didn't have any of those nice 3 features that Dr. Wani was talking about. If I did have concern for any type of invasive disease, then I would want more of an en-bloc resection and would be thinking about more potentially endoscopic submucosal dissection or ESD.
That's right. So I think if the decision making it really hinges on whether you suspect cancer or not. One of the basic principles of resection in terms of oncologic management is to ensure that if you have a suspicion for underlying malignancy, you get it on block, because that's the only way you're going to know exactly the histology and the depth of invasion, which obviously then impacts what you're going to do for that patient. So if there was a concern for malignancy, this patient should undergo endoscopic submucosal dissection for the most part.
And as Dr. Muthing said earlier when she was talking about this area, she was going to switch to this snare. This is a cold snare. As you can see, it's kind of got a more unique shape, and it is good for grasping onto those smaller pieces there.
Larissa, how often does this happen when you're resecting, where you need to use a cold snare in addition to hot snare resection?
Okay. I would say it mostly tends to happen in these kind of flatter lesions. And then any lesion that has any kind of degree of scarring. You know, the thing I really like about this snare is that you can really use the suction to kind of help pull up that scarred down flat area that the snare likes to close, slip over.
Okay.
Cut.
Okay.
And it's really safe, right?
And then, and yeah, that's the other thing. Like, I feel very comfortable with using suction to pull up a lot of tissue, and for these like little bits that are just kind of left over, you know, the last thing I would want to happen is a muscle injury at this point in the case. So it's nice and safe to switch to this option. Open. And definitely close. Using the cap here can help you pull up that tissue, and really kind of get to those more of those scarred areas. We can take this out.
Okay.
And you can see that the oozing is not bothering Dr. Muting at all with her resection. She's continuing with the resection because whatever you're seeing will stop fairly quickly.
And then when I feel like I've gotten to a point where I've resected all resected all the visible polyp, my next step is really to do a very thorough exam of all of the edges and ensure that I don't see any visible polyp left over. You know, the cap is also essential in this. If I was doing this without this distal attachment cap, my visualization would be so much poorer. And I'm able to kind of splay open this polyp and really see those edges. But you know, in piecemeal resection, we want to make sure we're not leaving any visible polyp left over. Prior
Larissa
to then.
and Christy, this is looking so beautiful. I don't see any residual polyp, do you?
No, I agree. Then I'll take
What's your next step, Larissa? Are you going to now ablate the edges, and then are you planning on clipping the mucosal defect shut?
Yes, yeah. So my next step will be to ablate the edges with soft coagulation. There's really good evidence for this step, and really helps to lower that risk of recurrence. You know, data has showed that with piecemeal resection, the risk of recurrence can be, you know, 15 to 20%, but this technique helps really bring it down to less than 5%. Tip out. Thank you. And, you know, just speaking to the quality of our nurses, you know, we also have Summer in the room with us who knew what I was doing and already switched my hotter unit over to our soft coagulation setting. Just using the very tip of the snare here, and then goal here is to ablate, you know, the outer few millimeters of the margin of the polyp to lower that risk of recurrence. The other nice thing about this technique is I can use it to touch up any oozing areas. And then, yeah, my practice, especially for right colon lesions, when I have resected using cautery due to that risk of delayed bleeding, is to close with clips to help lower that risk of delayed bleeding. We're really doing that to lower the risk of bleeding. You know, we feel nice about our site here. There's no concern for any deeper injury. So it's mostly to lower that risk of bleeding.
Dr. Muthing and Christy, thank you so much for letting us watch your case and explaining everything so beautifully. It's we're getting close to the time for our next lecture. So Dr. Muthing had said she was planning on closing this with clips, and we saw a little bit of that in both the poem and EMR talks. So we're gonna head on out and get to our next lecture. Are there any parting words or pearls of wisdom you wanted to leave us with?
No, thank you all so much.
Okay.
And thank you for your questions. And yeah, please let us know if any other questions come up.
Okay, thank you so much.
Congratulations, Larissa and Christy. This
Thank
was
you. Thank you.
amazing. This was amazing.
Okay, very excited for our next speaker. As you can see, he's meeting all his adoring fans as he's walking up. No, it's okay. I'm doing your intro. You're fine. This is Dr. Eric Vomini. He was one of our beloved fellows, and we are so excited to have him back this year. He's going to be talking about pancreatic pseudocysts, which is a big interest of mine. I hope you guys enjoy it.
Awesome.
Yeah.
Oh my God, I know.
Oh, here's your clicker.
Oh, nice. Clicker. Hi, everybody. I'm Eric. I was a former fellow here, and I think this course is amazing for all of you. I hope you guys all take it in throughout the weekend and just enjoy this, because I remember when I first came to this course, I was just blown away by the expertise at every single level. I think on the nursing end, you guys are the engines, the workhorses of all these cases, and just seeing how much you can learn from seeing so much complex endoscopy happening. But I'm here to talk about pseudocysts, so we're kind of shifting gears from a nice, beautiful resection. And I love this graphic that was just automatically generated, because this is really, as we go through this, really what's going on. They couldn't have picked a better AI. Couldn't have picked this beautiful network of surrounding assists. So I have no disclosures. I've got some objectives for CME, but so let's just talk a little bit about the pancreas. Okay, so there's pancreatic anatomy. It's seated mostly behind the stomach, and that's about 2/3 of the gland. And it's broken down into a head, uncinate, neck, body, tail. But when you're in the stomach, you're primarily seeing or around the neck, body, and tail portion. But it does have a little component of it nestled or cuddling up in the sweep of the duodenum. And so, are you able to see my pointers, or do I need to do the? Oh, okay. All right. But in this end, this is the duodenal sweep. And this is where you're going to find the other third of the pancreas, that being the head and the uncinate process. It contains a ductal system, very similar to like the branches of a tree. okay, or the lung that we think of. But it has a main duct that branches into littler ducts, and those littler ducts branch into even smaller ducts, and those that kind of network comprises of this main duct, but within these things called side branches. So when you hear a side branch, it's these little itty bitty branches off the main duct, okay? And that's really important with what we're going to be talking about. A little bit more into the anatomy, just bringing it down to like a little bit more granular level because it's really important. There is two components of the pancreas. There's the endocrine function and there's the exocrine. And that's just fancy doctor talk about hormone functions and digestion functions of the pancreas. So endocrine, we think of insulin, we think of, glucagon and all the stuff that we think about with diabetes. That is the one hat of the pancreas. When we're talking about pseudocysts and all the pancreatitis injuries, we're thinking about the exocrine, or the stuff that the pancreas does to help with digestion. So there's two types of cells of the pancreas that are really important in the exocrine function. That's the acinar cells and the intercalated duct cells, okay? These are within those little side branches, and the very distalist most, or the very granular furthest away from that main duct. Acinar cells secrete enzymes that we use to digest. So those are things like lipase, elastase, proteases. Intercalated duct cells, they actually secrete bicarbonate to help with the pH of how we digest things within the duodenum. It also helps protect the duodenum from getting too much acid exposure. So bicarbonate is a base, okay? It's the opposite of what we think about in the stomach being the hydrochloric acid, right? And we think acid, burn, chemical burn. So this is like our little buffer in the small bowel that helps us from getting a really scary chemical burn. So those very, further away from the main duct cells, they secrete into something called an intralobular duct. Okay, so these are the tiniest of the ducts of the side branch. Those drain into interlobular ducts. So those are just bigger collecting ducts. And those together will come together from multiple parts of the pancreas to secrete into the main pancreatic duct. Okay, so when you're thinking about a side branch, it's anything along the way of these two, okay? These are going to be most often what you see. These are really flimsy parts. You really are not hoping for a main duct injury that leads to a pseudocyst, okay? So this is very important for us just to kind of conceptualize, because this is the source of where we're getting our pancreatic fluid collections that lead to pseudocysts, okay? So when we think about pancreatitis, you really need to equate that to injury to these cells. Okay, so we're talking about just inflammation to the pancreas. So acinar cell injury, and you can get that by multiple pathways. So interstitial edema, or the surrounding infrastructure of the pancreas, can get edematous from, like, say, a stone or any type of stricturing obstruction. So you're just getting a lot of fluid that's gathering around. That leads to ischemia, because there's little itty bitty blood vessels that supply this. Swelling will compress those blood vessels, leading to poor blood flow, leads to inflammation, okay? It's very similar to what happens when you get a gallstone in your gallbladder, okay? Gallstone is, you get a gallstone obstructs your main cystic duct, your gallbladder gets really distended, and then all of a sudden the blood vessels within the walls of the gallbladder get compressed, and that's what leads to cholecystitis, okay? Very similar to pancreatitis in this pathway. You can get toxicity. I think many things can cause inflammation that we ingest. I think we often associate it with alcohol. I put a little asterisk because alcohol is not definitively shown to be directly causal to cause pancreatitis. It's it's been strongly associated with chronic pancreatitis, but if you see people who binge alcohol over and over again, many of them do not get pancreatitis. What they think that is actually with alcohol, it has to do more with often predisposition on this other side being defective cells. So a lot of times people who get alcoholic pancreatitis. They have some underlying genetic predisposition that basically their threshold to get pancreatitis is lower. So we talk about genetic hereditary pancreatitis conditions, things like you'll hear like PRSS1s and SPINKs and all these different alphabet soups of genes that people get labeled with that you see in their charts with all the fancy doctors speak, you know? But those patients tend to be the ones that have either a carrier for one of those that are actually more common than we think, that have that predisposition for alcohol. But either way, you're getting some type of collection towards an acinar cell injury. And what happens in that case is acinar cells will have these activated enzymes that will then be exposed to the gland. You're literally getting a chemical burn to your pancreas or the surrounding tissue. And why is that scary? It's because you have a lot of fat in that area, you have a lot of protein, and the pancreas is supposed to be breaking that down. What the scariest thing that comes out of the pancreas that I worry the most about is that the pancreas has an enzyme called elastase, okay? What makes up elastin, which is the integral part of that area, are very strong blood vessels, so arteries and veins. So you can get hemorrhaging in that area, okay? So we talk about just kind of redirecting this towards the pseudocyst progression and what really is going on, I think, the macro level is we get some type of acinar cell and ductal injury. So on CT scan, this is a beautiful kind of progression within this patient. You see like kind of really puffiness and what we term fat stranding. So these little wisps around the pancreas, and unless you're literally looking at these every day, you sometimes don't appreciate it, but the pancreas should be pretty well defined, kind of like how this liver is, right? Or the stomach, right there. So it's just very puffy, and that's just edema causing a little artifact within that area, so you don't see it real well. And that over about a week, you'll see this puffiness start settling around the pancreas. And so this dark part, these are what's termed an acute peripancreatic fluid collection. Okay, so bear with me, okay? So we're getting into the alphabet soup. So APFCs. And then over about 2 to 4 weeks, this is going to collect and your body's going to do a beautiful thing that it does and start building a barrier around it to try to heal this and inform something called a pseudocyst, okay? So progression from initial injury to a nice, safe, walled off collection, about anywhere from about 2 to 4 weeks is usually what we see, more on the 4-week end. So why we keep calling this a pseudocyst? What is that? Why did we even come up with this term? So you can thank a pathologist for this, okay? So pathologists like to, be very, fundamental and strict with their definitions, okay? So medically speaking, a cyst needs to have something called an epithelium layer. So within the capsule, meaning there needs to be a special type of cell lining within this structure for it to be specifically called a cyst. Pseudocysts, when they form, take that inflammation tissue around it and kind of encase that. That is not a cyst, quote unquote, per se formation. It's just hardened inflammatory tissue, what we term granulation tissue. So this just hardened goop that's forming to help encase this from no longer being free fluid that glues together. So that's why we call it a pseudocyst. We don't have these histologic layers that we see in a true cyst. So what do I try to tell patients what this is? Because patients be like, you telling me I have a cyst, but you're saying it's a pseudo? I thought this is this like some type of pseudoscience? What's going on here? And I really just kind of liken it to something that's common. So I tell them they have a blister on their pancreas and they get it then. They're like, oh, okay, so you have this like big puffy thing that formed after a burn, and they just get it. So I tell them that you just got this big bubbly blister on your pancreas, and sometimes it needs to be popped, and that's what we're going to talk about next, okay? So, but we're going to first just, again, kind of on the granular layer, I want to tell you what really is happening, okay? So what really is important for us to summarize before we start going into intervention is you must have an injury to somewhere along that ductal system, okay? And either in the main duct, which you hope is not the case, but equally the side branch can be an annoyance, but tends to be a little bit less severe. but you need some injury. And what would cause that? It could be pancreatitis, so activation of those enzymes that I talked about. You could have trauma, so someone getting in a car accident or a penetrating injury. I work on the south side of Chicago. We see a lot of gun violence, unfortunately. I see tons of pancreatic pseudocysts from bullet holes going into patients. So surgery is also one of those things that you will see pseudocysts form. Why is that? Because they're intentionally causing trauma. They may inadvertently cause an injury to a duct that they may not have meant to, or you have blood vessel supplies that may not be healing. You may get a focal area of ischemia. Those acinar cells may get inflamed, cause pancreatitis, yada, yada, yada. You get a ductal injury, and now you got a fluid collection and so forth. When I mentioned that timeline, right, of it taking about from about 2 to 4 weeks to happen, why is that like so universal? And within your body, you have an inflammatory reaction. I know probably some of you remember all the way back to physiology class, and they talked about like fibrosis and how you got stellate cells to be activated, and you talked about all these alphabet soup enzymes that got activated, and you instantly forgot it, like the Krebs cycle, right? But why that actually happens and why it takes about 2 to 4 weeks of continued activation of that inflammatory process to start forming this or activating the cells that make fibrosis around fluid collection. So that's why that happens, and that's why that is the scale it takes for about 2 to 4 weeks. What's really important is that most often these are sterile fluid collections as well. The abdomen around the pancreas should be as sterile, hopefully, as the OR that you're in, okay? There is instances where you can get contamination and infection of pseudocysts. Those are scary, okay? Why that may happen, you could get bacterial translocation, so inflammation, and your gut is filthy, right? You have this billions of germs, and inflammation may loosen up that barrier that you have and get into that peripancreatic fluid collection before it walls off. And now you've sealed that peripancreatic fluid collection with inflammation, and now you have a perfect broth for bacteria to germinate, right? Other things like you could have had, unfortunately, like a surgical contamination. Most scariest thing, in my opinion, is like you've had a lot of inflammation in the area, and you've got now a fistula or an aberrant connection between the duct, or the cyst, and something that's contaminated, being like the bowel. How do they present? Again, you have to remember, when was their pancreatitis, abdominal trauma, or surgery? So that's in the back of our mind at all times. Because again, it's important that if they're not hearing about that and you see a cyst, it could not be a pseudocyst, okay? This could be an IPMN that we hear about, or another mucinous cyst. So if you're not getting that piece of history when they present, you need to start thinking about other things. And it's also, again, like we talked about, important for timing of intervention on these. Classic symptoms for pseudocysts, you may get abdominal distension and bloating, right? This is right by the stomach and the small bowel. You're getting food put in. You have something that's like expanding like a balloon, right? And it's starting to press on that. So you may get fullness, early satiety. So you eat a couple bites, ugh, I don't want it anymore. Abdominal pain because you have a lot of nerves, so your enteric nervous system in that area. Nausea, of course. But often you don't feel anything, okay? Your abdominal cavity has a lot of space, correct? You have a lot of room for this to start getting bigger and bigger before you start feeling those compressive symptoms. Again, worrisome things would be if it was infected, and that's actually less common, right? This is supposed to be sterile. But if you're seeing things like fevers, hypotension, decreased urine output, or respiratory distress, you're really concerned. That can be pretty worrisome, that you need to have some type of urgent intervention. Nurses, I love, because you guys are so good at knowing all the instruments that you've learned throughout training, whether it be for Foley's or or bladder pressures, all that stuff. And so I feel like you all know when these are turning south faster than a lot of doctors do. So why would a decreased urine output happen? Well, you could have a big expanding pseudocyst that's taking up the full cavity. You all know about intra-abdominal pressures really well. You may pick up on that a little bit faster than doctors will, but that would happen because the IVC, this main vessel that's traversing the abdominal cavity, is starting to get compressed on. You're getting less cardiac return or cardiac output. and venous returns going down. So a little bit more urgent situation that you need to pop this pimple or this blister faster. So when we're talking about treatment, you have to first bring it down pretty basic. So are they symptomatic or are they not? So a third of all pseudocysts don't need intervention. And just that as far as data looking, you won't intervene on any of them because about a third of them are going to be asymptomatic and you can just watch them. Okay, but of the 2/3 that do need to be intervened on, those are the ones that are going to be the symptomatic ones. So presenting with those symptoms that I had discussed. You have 3 little buckets or silos that you should be looking towards. So you have endoscopic management, which I like to think of as, we're in an endoscopy course, obviously, is the best option. You have percutaneous options, and really, in my opinion, should be reserved when endoscopy is not available. And then your last resort now is surgery. Okay, you have just all the morbidity that comes with surgery. We try to avoid these two because it's not just like the procedure, it's all the mess that can come after. It's all the collateral damage, the baggage that comes with doing these. Of percutaneous options, the biggest one I worry the most about is, yes, it can drain a pseudocyst really nicely, but that is pancreatic enzymes. Those enzymes are meant to cause inflammation or basically chew up everything that you see. And you're putting a connection between the skin and the pancreatic fluid that's within that cyst. And we see high rates of pancreatico-cutaneous fistulas. You want a hard fistula to resolve. A pancreatic cutaneous fistula can linger for years, and it can make people miserable. We have something that's meant to chew up and make things dissolve, being pancreatic fluid. Imagine pouring that on your skin over and over and over again throughout the day. Patients can be very miserable. So we try to avoid those. Sometimes they're necessary because you have a collection that's been away from the reach of the endoscope, and you need to bite the bullet and try to get that out as soon as possible. Of endoscopic management, you have really 2 big buckets. You have transmural, which I like to think is EUS based, and transpapillary, which was ERCP. Transpapillary really came first, and they each have their benefits. But since the advent of EUS and interventional EUS, meaning like things that we do during EUS, not just looking, we have had such great success in improving these outcomes. So I'm just going to kind of go for the rest of the time looking at the different modalities we do within endoscopy. So I think within transmural, so we're in the EUS bucket, we have cyst gastrostomy. So cyst being the pseudocyst, gastro being from the stomach, usually ostomy, meaning we're creating a hole or a connection, okay? And we use primarily right now, I think for the most part, lumen-opposing metal stents. You'll see this, the trade name, you see them from Boston Scientific, Axio stents. You have other ones in different countries, but primarily this is the major share of the market when we talk about LAMs or Axio stents. What it really involves from the procedural side, and it's an intentional perforation, okay? You're burning a hole into the stomach or the small bowel, wherever the pseudocyst is easily accessible, and you're entering the pseudocyst under like what's that yellow pedal, or what we trying to term pure cutting current. Now, a lot of your electrocautery units, whether you're using Irby or whatever, these are your, mostly, cutting features and lot less of the coag. So you're not going to be hitting blue pedal. So you're going to be hitting yellow pedal to just really fast get through and through because you want to immediately seal that perforation with the stent deploying. This is a bougie catheter that the tip is kind of conical at the end, so it's not meant to make a big hole. It's meant to make basically a sealing hole as it goes across. Excuse me, I hit the mic. And then what you'll do is you'll deploy both ends of the flange of the stent, and it will just immediately drain that into the stomach or small bowel. I think it's really important because sometimes these can be really big, that you have these patients in a good position so that they don't aspirate. Very rarely for pseudocysts, I will ever not intubate these patients. There would have to be a significant, issue with intubation. They have a lot of issues with fistulas and, or, esophageal bronchial fistulas or something that would be putting them at risk for an issue. And if that's the case, I have to be very gentle when I'm doing this procedure. What's the benefit of this the most? It minimizes leakages around when you puncture, and it's a large caliber stent so patients get immediate relief almost. So here's a video I have. I hope this works. Isn't that what everyone says, like during every presentation? I hope this video works. Oh. Okay, so here's Kirsty, my partner. So you saw that burn, that kind of flash bubbling over here. Here. And that was the catheter burning through the stomach, okay? And now you're gonna start seeing the flanges be deployed. And there's what's known as the proximal flange on the endoscopy side being deployed. And now we're gonna be pushing out the catheter. And this lumen-opposed stent or metal stent looks exactly the same on the other side. So now that little hole in the middle of that stent is where the fluid, now you can see a nice start trickling out. You try to use usually the largest stent you can get in, but you want to make sure that, you're not putting too big of a stent in. So these come in 6, 8, 10, 15, and 20. Usually I'm reaching for 15s and 20s for this because I want immediate drainage, good drainage, but I want to make sure I'm in the right position. I'm not going to obstruct the pylorus. So the patient now goes from having an obstruction from a pseudocyst, now they have a gastric outlet obstruction from my big flange right here, okay? So it's kind of an art as opposed to a science of which is the best, I would say, but most of them are going to be 15s and 20s, okay? Okay, so double pigtail stenting. This is the old school way, okay? This is before lumen opposing metal stents were introduced. Works really well still, okay? It's less likely, like I said, to be performed when now it lands here, but it's still performed. Like I did one of these about 2 weeks ago. The most often reason why we will do a double pigtail cysgastrostomy is because that lumen opposing metal stent needs a certain amount of distance or less between the bowel and the pseudocyst. Otherwise, we can misdeploy the stent. So if you have a little bit more length between the wall of where you are and the cyst, you may be reaching for this just because this gives you a little bit extra length. Because if you see on, I'll show you in a second, you have the main portion of the stent, and then you have the little holes on the ends where the pigtails are. So what this includes, you'll puncture the pseudocyst, usually with a 19 gauge FNA needle, whatever your dealer's choice of what that is. You'll place usually 2 guide wires side by side. Nice little trick now is, you take a cytology brush over one of those guide wires with the cyto brush removed, and now you have another hole access, so you can put both wires in when you actually only punctured once, instead of trying to puncture once, put a wire, and then have to reposition, puncture again, and get a second wire in. It could be a little bit cumbersome. Depending on the how firm and dense the inflammation is, and how big the wall of the pseudocyst is in your stomach, and what the kind of clinical presentation is, you may have to use some cautery still to get your double pigtail stents enough room to get into the pseudocyst. So using a cystotome is often used. Now, some of the devices that we've used for like biliary dilation, so your balloon dilators, have gotten a little bit firmer, and you can give a little bit of back tension on the wire to kind of get it across to even create that room. And then what you'll do is just deploy the double pigtail stents one at a time over each guide wire, usually under fluoro. Again, the downside of this is you're using a smaller caliber stent. So these are usually 7 or 10 French stents. Usually on the 7 French, it's just hard to push a 10 French double pigtail through things, especially when you're using an EOS elevator as opposed to like an ERCP elevator. So you may not get as immediate drainage and symptom relief as you'd like, and sometimes they can clog. The other big thing is every time we do those exchanges, you're pulling something in, a catheter in and out of something that has just been popped, right? So you can get leakage of this fluid around a sterile space. So you can possibly, if it was infected fluid, or it's got some bacteria in it from translocation, you now have contaminated the peritoneum. Now you have peritonitis. But also just fluid in the abdomen is painful, okay? You think about bioleaks. Bioleaks can cause something called bilious peritonitis. It's not pleasant for patients. Our goal is not to do a pseudocyst and then give someone peritonitis for pain. So you want to minimize how many exchanges you're doing, and this is the one thing that can be a little bit of a downside. Here's a nice little example. I don't have the video of it because it's so old, but you can see the 19 gauge needle up here in the pseudocyst, and then they would coil wires in here. and then advance the double pigtail stents. And you can see those are the holes that on top of the actual patency of the stent itself, but those little holes will help with drainage. There is transpapillary drainage. It is, I would say, the least often performed, but I still do it often if I get the opportunity, or I'm provided the opportunity, because it does work really well. The most often we will do this is if someone has some type of symptom, but the pseudocyst is just too small to fit some of these other stents, okay? So those Axio stents or luminopolsin stents, they need a certain amount of space to deploy those stents safely, okay? Especially if you want to use bigger ones, you're needing like at least a 3 or 4 centimeter cyst, usually a little bit more to make you feel a little bit more comfortable. Transpapillary drainage doesn't rely on that, okay? You have, like, say, for instance, someone with jaundice, and they have a pseudocyst forming right where the bile duct and the pancreatic duct are meeting, and it's compressing your bile duct. And so we need to get this decompressed somehow, but it's too big or too small for us to fit our EUS guided approaches. And so this would be a perfect example of when you would do it. What happens with this? It's just basically doing an ERCP. You're getting the wire to go into the pseudocyst or around the pseudocyst, and you're placing a stent. Excuse me. So what you'll do is you'll place your pancreatic duct stent. You'll inject some contrast to help localize where the pseudocyst is really taking off. So seeing where the injury is. Often your endoscopist will do a sphincterotomy in the pancreatic duct. So we think about biliary sphincterotomy. This is one of the indications for pancreatic orifice sphincterotomy. You do that because you want to place a stent that's at least 7 French or 10 French, and you just need more room to make that. So that's why that cut is made. Also, will collapse the pressure within the pancreatic duct to help with collapsing the stent. Okay. Why this kind of has fallen out of favor is because we worry about causing more injury, right? When you're cutting, you can cause bleeds, like a post-ERCP bleed. You can worsen pancreatitis. It's not as common, but it still can happen. And it's more from the initial cannulation. A lot of times they're not getting pancreatitis from the contrast that you inject because it's just spilling out into the pseudocyst usually. But sometimes these cause strictures in the area, and you can get a retainment of contrast. That's where one of the ways you would get contrast-associated pancreatitis. But usually the pancreatitis can occur from that initial cannulation. You're futzing around, and then you cut, and you cause a burn to the area, and that cautery inflames the pancreas. So you could, cause even more pain. But you can help minimize some of this stuff, again, with some IV fluids and indomethacin, and then really trying to get that stent in place. Here's an example that I did, okay? This was about a month ago. So I was doing an ERCP. This patient was jaundice, had pancreatitis, had a pseudocyst. I was just planning to just place a stent because I was planning to, he wasn't super sick otherwise. He was fine. It was really reliable. It was going to come back as an outpatient the next week when I had enough time to place an Axios in. And you can see on this first picture, I already have the biliary stent, but my first wire I got in was this big guy that was just looping up here, and I knew exactly that was in the pseudocyst. So I got inadvertent advantageous. It was like one of those things where you're like, yeah, I meant to do that, it was that was it. That was the plan all along. But I basically got the wire went into the pancreatic duct, but then automatically went into the pseudocyst, just coiling all the way up there. And this was spilling out on my sphincter tome. So you do enough of pseudocyst drainage, you kind of pick up on how they look when the fluid looks. And I knew right away that was like pancreatic pseudocyst juice. So I placed a biliary stent, did a sphincterotomy, and you can see, I don't know if I can see it over here. Right here, I don't know. You can see my double pigtail that I put into the pseudocyst. So that's a classic transpapillary drainage. Patient came back 4 weeks later, upsized the stent once. 4 weeks after that, pseudocyst was gone. So, like I said, these can become infected, but you're going to hear a little bit of jargon in between pseudocyst, walled-off necrosis. They seem kind of like the same thing. They're actually not. Okay, so pseudocyst walled-off necrosis is you've gotten a really bad pancreatitis, so much so that the pancreas is starting to necrose. and then it's starting to liquefy and turn into goop and everything, yes, you may get ductal injuries. You may get all sorts of stuff that, gets encased. Pancreatic fluid, pancreatic, parenchyma, all that stuff may get kind of brought into that soup pot. But it is not technically a pseudocyst, okay? But it does form that same wall that you see with pseudocysts. It's this inflammatory encasing. So the thing with pseudocysts that look like Waldorf necrosis is that when they become infected, you'll see very similar debris and pus coming out. So I really, it's kind of a misnomer that a lot of people will just be, oh, he's got a Waldorf necrosis. Well, it's actually maybe just be a pseudocyst that got some pus in it. So they are different things. So like I said, infected pseudocysts do require a little bit more. This is like urgent stuff. We're not waiting sometimes that full 4 weeks. There's been a couple trials that were published in the New England Journal of Medicine about last year, or excuse me, 2 years ago now, that showed that you can actually don't have to wait that 4 weeks. You can actually go up to 2 weeks and be ready to drain these. These are those patients that you're trying to stabilize for as long as you can. Sometimes if they hit that 2-week mark, you're good to go. So prognosis. We're kind of wrapping up towards the end, but prognosis is excellent of pseudocysts, okay? We have about 90% resolution when you have an intervention. Remember though, of those 90%, all that stuff, a third of them weren't even included in those studies because a third of them will resolve on their own. So that's great. The best thing to do, the best pseudocyst therapy is not having to do anything, right? You don't have to put the risk of pancreatitis with futzing around by the papilla. You don't have to worry about perforation complications, leaks, all that stuff with all these stents. So sometimes you don't have to do anything. So this is very good prognosis. And that's something you can tell your patients. What is some of the stuff that leads to better prognosis if you identify these pseudocysts before any end organ injury. So your AKIs, your respiratory distress, abdominal compartment syndrome, any type of evidence of like a heart attack or, an NSTEMI happening, a type 2 NSTEMI. These are all things, if you pick up on the pseudocyst before that and start the treatment pathway, they tend to have better outcomes. Better prognosis on top of that would be people with obviously no symptoms. That's always the greatest. And size is less than 4, as long as they aren't impinging on the bile duct, okay? I always stress that because cholangitis is one of the most lethal infections of the body. So less than 4 centimeters, you're not going to get as compression around this tight space where the pancreas is. But overall, pseudocysts less than 4 centimeters, if you look at the entirety of the gland, tend to have better prognosis. Worst prognosis is they follow these patients a little bit over about 30 days and then 90 days. If they continue to have alcohol abuse after their pancreatitis episode, I think that has to do more with the disease of alcoholism more than anything. Alcoholism tends to affect the prefrontal cortex. So you have people who tend to replace nutrition with alcohol. So these patients who are recovering from pancreatitis and pseudocysts and all this hospitalization, they don't eat as well. They don't hydrate as well. So they tend to have poorer healing abilities. So that's why their worst prognosis is with that. Severe pancreatitis, again, that kind of dovetails back from the detection before any end organ injury. End organ injury is basically a definition of severe pancreatitis. Asymptomatic pseudocysts, there's, like I said, just very little role for continued imaging in these patients unless symptoms start to arise. I like to have them follow up with me in clinic just once, about a month later, just to check in. I like seeing at that 30-day mark that we see for measuring, patient outcomes. Just seeing them in 1 month, hey, it can be, a quick visit. Hey, I saw you in the hospital. I didn't do anything, but I just want to see how your pancreas is feeling. Are you getting any new symptoms? Anything? But given the injury to the patients, I think it's worth your time just to make sure that they understand that this isn't just an in-hospital thing. It may require a little bit of follow-up after. Some conclusions: pseudocysts require not only pancreatitis, but also an injury to the duct. So that, again, I can't stress that enough because there's so many times your team's going to get it referred for a cyst and it looks like a pseudocyst, but it's actually a giant atypical IPMN. You do not want to throw a stent into an IPMN, okay? that is going to lead to poor outcomes. Okay. So you need to have that piece of your history. So if your physician has not heard about that, maybe you ask the patient, hey, how was your surgery? Was it hard? Did you have a lot of, did they have to go in? And you go, hey, doc, I think this might be actually from a ductal injury from their surgery. You know, this is where the only time I really saw in the chart review about them having a ductal injury. You know, the inflammatory process takes weeks to solidify, but that's because we want to make sure the intervention is safe if we have to. And because of that, sometimes it's just asymptomatic. You don't need to do anything. It's happening a third of the time. But I think in the back of the mind, we've gotten to this stage in endoscopy that you all are in now. We have so many interventions. However, each one of these is very effective, and it's about finding the right patient. Okay. Those are my references, and thank you. I don't know what my time was like. Sorry. Did I go over?
Yep. Never change.
I know. Thank you.
Does anybody have any questions for Dr. Momini?
For most of these cases of pancreatitis, are you giving indomethacin or is it kind of patient related?
It depends on what you're doing. So transpapillary drainage, I do. If I'm doing transmural drainage, so if I'm doing an ERCP to put a stent, a pancreatic duct stent, into to drain the pseudocyst, yes, I will give indomethacin. My group gives actually indomethacin to every person who's getting an ERCP, whether or not it's your initial or follow-up ERCP. The cost is the issue on that. So that's a trade-off. But we did see a lower risk of complications with recurrent post-ERCP pancreatitis. So in these patients who've already been cut. Okay. So yes, if I'm doing ERCP, yes. EUS, no, because you're away from the pancreatic orifice. You do not see. We don't benefit from medicine. Oh, that's. This is inflammation will start going through the scarring process itself. And those fistulas will start to clamp down and it'll close up like an ear piercing. So it's really cool. A lot of times this has to do with, if you remember back to like physics classes and everything, with your hydrostatic forces and your oncologic forces where you have like high pressure to low pressure, right? What happens is when you burst a pseudocyst with a stent, you are creating a big drop in the hydrostatic forces. That's why the fluid is flowing out in the stomach. And what you get essentially a collapsing environment that these pseudocysts start collapsing in on themselves, including the fistula itself. So there is a physics component to this, that the pressure itself is even collapsing on the fistula itself. I can count on one hand the amount of times I've had to close a fistula. It's actually been more with people who have undergone different like transmural, like Axios or interventional EOS procedures, but I've never had to do one for a fistula. So, but to answer your question, yes, they often will just collapse on their own. What's really neat about these, especially with pseudocysts, sometimes they can cause enough irritation that they auto fistulize. So you go into do a procedure and you already see a fistula formed. They've caused that transmural drainage by itself. I've seen that sometimes a little bit where it's a little bit more crowded. So if you have a pseudocyst forming in the head and the pseudocyst is just super inflamed and it's running up against a very thin-walled part of your bowels, being your duodenum, it doesn't take much for continued inflammation for the walls to start separating and fusing together. And you've just had a stent essentially placed, but the body did it on its own. For those patients, what I like to do is just place a double pigtail stent to make sure that it fully collapses, but I don't need to put one of these huge stents in. Yes.
I think I used to work at Joe, the doctor that I worked with, would always bring patients back in like once a week to do next time.
Mm-hmm. Yeah. Sure. So that's where I think what you're referring to is where that confusion between pseudocyst and walled-off necrosis is. Pseudocyst usually is a sterile fluid collection that when you drain it, that's all that's usually in there. It's just pancreatic juice and inflammatory juice. That's it. What I think your physician was referring to is having to do necrosectomy. That's where you get necrotic pancreas that just goops up, and you have to literally debride out that tissue. That's where you bring in, them back every week, or if they're admitted, sometimes twice a week. And then the surveillance on for CT scans, I will do one after I've removed the stent, and it's more to see if I'm seeing any evidence of recurrence. Remember, these are 90-ish% effective. There's still going to be about 1 in 10 that are going to recur. Okay, despite all these advances. So I do usually do one. If it's still not grown back, usually after one, and the chances of it coming back are pretty low. I try to minimize how often I'm irradiating patients. I don't want them glowing in the dark. So if they're asymptomatic, I don't continue. And I've seen progress, and I've seen on endoscopy that when I remove the stent, for instance, if I've done a transluminal or transmural drainage, so those axial stents, if I've seen that cyst cavity just collapse onto the wall of the cyst and I've removed it, I'll do one. And they're asymptomatic. I'll do one CT, and then that'll be about it. I'll continue to follow them in clinic. I think there's no harm in seeing patients, right? You have them check in 6 months from now. It's okay to discharge them a year later from your clinic. They don't, and I think patients, they go through hell with these episodes. These are terrible presentations. Patients are scared. They often are jaundiced, or they often had essentially a bomb blow up in their abdomen, and they're in horrible pain. They don't ever want to have that. They can end up getting a lot of anxiety and poor quality of life. There's actual data on the quality of life in people with really severe pancreatitis. So it's good as the physician or the nurse practitioner or whatever who follows these patients to just check in on them and just reassure them that, hey, your symptoms are not there. We don't need to do imaging. I know you're worried about it, but it's reassuring to me. If I feel good about this, I'm really happy. You should be good. You should be feeling better about it. Okay. Other questions?
Just one more. Just because we have a mixed group here, you had briefly mentioned, and you can give a brief answer as well, IPMNs and us not wanting to stent those. Could you just talk a little bit about what an IPMN is
Sure.
and why we wouldn't want to shove something in there?
So what you'll learn is we get referred for cysts of the pancreas, and there are different cysts that occur. One of the most common cysts that we see is something called an IPMN, or intraductal mucus papillary neoplasm. So that's why we call it an IPMN. These are essentially like the polyps of the pancreas, but they're in cyst form. Okay. They do all have a degree of malignant potential. Most will do nothing, but they are not a pseudocyst in that pseudocysts have zero malignant potential, right? Mostly IPMNs, because you don't want to put a stent in those. So it's because eventually they may need to have some type of procedure on them. And putting a stent in them could be catastrophic. For one, they could potentially, if they have any type of dysplasia, they may not act well and start not healing well with a stent in them. So you could get a huge leak. You could cause not only pancreatitis, but peritonitis from doing something like that, because you'll have continued pouring out of leakage of pancreatic fluid from them. The other thing is it may make it very difficult for a surgeon to remove them. Okay. We're creating fistulas, which creates inflammation, which creates adhesions and all that stuff. And if you have someone who has a malignant or a pre-malignant cyst, like an IPMN that's become aggressive, you really want that to have a definitive management, right? You want that out and have a good margin. And if we're hindering surgeons from having a good margin, we're not doing the job we should be doing, okay? So sometimes what we'll do, if we can't tell and you're not getting a good history, is even though it sounds like a pseudocyst, it looks like a pseudocyst, it's walking like a pseudocyst. Sometimes you may actually do an initial EUS just to do an FNA and sample and prove that it's a pseudocyst first with some of the fluid analysis up front before you come back and place the stent. Don't worry about, they'd be like, oh, you're draining all the fluid or anything. These things will reaccumulate if they're going to be symptomatic, okay? So sometimes you want to be a little bit careful if you aren't getting that good history, okay? So sometimes you'll see your endoscopist just do an FNA up front before they actually drain these. So because this isn't all 100%. Everyone has a little bit of individuality on their pancreatic cysts. So. Cool.
Thank you so much.
This is great. Awesome. Thank you.
Botman.
See you all later.
Okay.
Wow. I feel like this is like a talk show.
All right, guys. So we kind of just powered through the last couple hours. I blacked out. We did not, if anybody had questions on poem, I want to make sure that we get those answered. I know that was, yeah, of course.
I had two questions. So one of them was one of the restrictions you had on patients who had poems. They were not allowed to eat seafood. Why is that?
I have to look into that. I actually don't know. I think basically the study just summarized at the end, like sat these patients down and said what feels good and what doesn't. I don't know. That's a great question. I have to get back to you.
It was seafood, liquor, and
Seafood, liquor,
Spicy
chili oil or chili spice.
Okay, I can look it up.
Yeah.
Do you have
a guess?
I have no idea.
Yeah, maybe.
Maybe it's a mercury thing.
Yeah.
Yeah. Okay.
maybe.
Second question. What happens? You said that tissue is really fragile in that area. So what happens if it perfs? Do you use a big clip? Do you sew it back together?
Either a clip right then, or we need to go on the floral table and probably put a stent in.
Oh, okay.
Because not only have we've cut the lining basically of the esophagus, and now if we made a perf, then now they're gonna it could go into their mediastinum and either pneumothorax. So we'd probably flip them real quick and throw them on the floral table and maybe do a little touch of contrast, see how bad it is, and probably throw a stent in them and let it heal.
Like a solid stent?
Like a metal long, not like the one, like the first case that we put that stent in, would be that kind of stent.
And then I don't want. And then if they perf, do they go back? Or I mean, they have to be admitted anyway after.
That would be, yeah. I think it's according to their symptoms, but I don't think they would have to go to the ICU.
We know why no seafood. It's because it increases reflux.
Oh. Interesting. I would have never guessed that. Ariel, I was going to ask you, what do they usually do out there? She's one of our charges back in recovery.
Um, before, like even before, like when it's scheduled, like when the nurse navigator puts it all together and then it gets to the scheduler, sometimes I have seen that the order for admission is already like in, because like when the patient shows up in the like notes, it'll already say um bed pending or something, like the order is already in for it. So it just depends, I think, patient wise, and what they talk to when they talk to the physician, probably like in clinic before they got their procedure done. Mm-hmm. Mm-hmm. Yeah, no, it hasn't been lately. Yeah, when we say it's a go, then we call them and then we tell our PAs or our NP and they put the orders in before they even get to recovery.
I've never seen it
Needle
after
decompression
during.
from a perforation or um I have done it one time. It's not, I think actually we were together. Um, it's usually very physician directed and more us just grabbing the supplies. Yeah, first thing for us is to remain calm. And then we focus on the normal things that we focus on with the perf. We're monitoring the patient, assessing their belly, looking at their peak pressures, making sure our insufflation is on ultra low. And then, I usually communicate with my provider, and ask, what would you like? And they'll tell me. But it's pretty rare for us to do needle decompression. So when they're doing like an esophageal poem, we intentionally pretty much always at the gastro esophageal junction, we're doing a full thickness. And then same with the G poem, full thickness. Just because you want to get all that. I mean, that's the main reason why you're there, is getting that sphincter open. And it's not really something that you can go back and redo once you've done it. So. Any other questions? All right, you guys are troopers. Sorry our break got moved up. It's been a long morning, but we're going to take a break for lunch. We're going to come back here at 1 o'clock. And then we just have a couple lectures left. So enjoy. All right, we're going to get started. Sorry, we're having some technical difficulties. I don't know who organized this thing. She's a mess. Anyways, so our next speaker is me. I am Lula. I work in interventional endoscopy here at UC Health. I've been here for about 4 years now, and my background was in like BMT and apheresis, so I knew absolutely nothing when I came to GI. and I've fallen in love with it. And so one of the things I knew absolutely nothing about or that it even existed was Barrett's esophagus. So we're going to talk about that today. So we'll start with a brief overview, and then I'll do a very quick spiel on clinical management, like what people would do on an outpatient basis. And then we'll talk a little bit more in depth about therapeutic interventions for Barrett's esophagus. So what is Barrett's esophagus? It's a condition where the lining of the esophagus is damaged. Normal tissue is replaced with metaplastic columnar epithelium containing both gastric and intestinal features. So basically, you've got your normal esophagus, and then instead of your normal esophageal mucosa extending down to your GEJ, you start getting this salmon-colored abnormal mucosa growing up. So it's diagnosed by the finding of that in the esophagus 1 or more centimeters beyond the GEJ. So it does get misdiagnosed. A lot of times we do get referrals, and it's just kind of like an irregular Z-line, but it's just barely. And then, so the definitive diagnosis is a biopsy is positive for intestinal metaplasia. So who is at risk? We have the majority of these patients are of the male gender assigned at birth, over the age of 50 years with Caucasian heritage, and have a family history. Those are kind of like you can't modify those risk factors. And then other things that will increase your risk of developing Barrett's esophagus is tobacco smoking and alcohol use, obesity, and then chronic acid reflux, H. pylori, and a hiatal hernia. I think in that previous picture, they have a hiatal hernia. You just have more of that refluxive acid because of that. So signs and symptoms, it's not super common to always have symptoms with Barrett's esophagus. Frequent heartburn and regurgitation of stomach contents is what we'll see most frequently. About half of patients with Barrett's report little to no symptoms at all. Others will have dysphagia and chest pain. Again, those are less common. I just kind of threw this picture in here, but this is just kind of a visual of what I was talking about with that salmon-colored mucosa. Okay, so complications, why do we worry about it? It's the only known precursor lesion of esophageal adenocarcinoma. Patients with Barrett's esophagus are at a slightly higher risk than the general population for developing esophageal cancer. So it's something that it'll increase your risk, but that doesn't mean just because you have Barrett's, you're going to get esophageal cancer. However, you don't get esophageal adenocarcinoma without having Barrett's, if that makes sense. So you have a less than 1 in 200 chance of developing esophageal adenocarcinoma if you have Barrett's, and then about 90% of Barrett's cases do not develop into cancer ever. So I have a photo here of what that cancer may or may not look like. It's very ulcerated. And then here we have an endoscopic ultrasound, which is another procedure that we do in the lab. This one is done with a radial scope, and it gives us kind of this circumferential view of the esophagus. And so you can see this is this hypoechoic, which means darker area here is the mass. And then you can kind of see it penetrating and how deep it goes. And that's how our physicians stage tumors. And also, if we're evaluating whether we can do an ESD on this patient or not, if it hasn't penetrated into the muscle layer, then we'll do everything we can to do a resection rather than an esophagectomy. Those procedures, I mean, we do them, or the patients will go to surgery if they need to. However, there is a high risk of complications with those. So if we can avoid that, it's what's in the best interest of the patient. Okay, so clinical management. This is kind of the algorithm that we follow. So we have that weird abnormal mucosa, And so to get our definitive diagnosis, we'll first do biopsies. And then depending on what those biopsies come back as, that is where their treatment plan will go. So if they have non-dysplastic Barrett's, we'll see them in 3 to 5 years for repeat biopsies. We'll reassess, see how much has changed, if anything. I'm going to skip that one. We'll go over to confirmed, that's low-grade dysplasia. So then we'll go through therapeutic interventions. Same with high-grade dysplasia. And then T1, again, that's staging. So if it hasn't penetrated into that muscle layer, endoscopic eradication therapy. If it's indefinite, we'll go ahead and optimize PPI therapy. I'm going to talk about that in a bit. And if it's confirmed, EGD with biopsies in 1 year, or manage per new histology. And sorry, I'll not repeat EGD, we'll repeat biopsies. That's what that's for. So as far as clinical management, we'll manage the GERD symptoms with, the usual suspects. I would say most commonly, we are prescribing these patients proton pump inhibitors. That is we're doing that with the intent of lowering stomach acid and, keeping the Barrett's under control as much as we can. It's definitely something that as nurses, we can educate our patients on, why it's important and why it's important to take it correctly, on an empty stomach in the morning and then taking that second dose in the evening. I think that's where a lot of patients, I'm guilty of it as well, just, they forget, or it's like, oh, you're already halfway through dinner, I'm just not going to take it, or I'm taking it in the morning, I don't have any heartburn, I feel fine, and then things can get worse. So Barrett's with no dysplasia, monitoring of progression. Oh yeah, I already said that. 3 to 5 years. So now we'll get into therapeutic endoscopy for Barrett's esophagus. So these are the things that we're doing over in the endoscopy center. The first one I'm going to talk about is radiofrequency ablation. This is for Barrett's esophagus that is not nodular, so you're not seeing any actual raised tissue, anything like that. You had high-grade dysplasia or low-grade dysplasia. This is kind of like your first line, not as invasive. Let's try and get rid of it this way. So it uses heat generated by radiofrequency energy to destroy the diseased tissue. So basically, we're just zapping it. I'll show you kind of what that looks like here in just a moment. Radiofrequency energy is delivered either circumferentially, so we can do the whole esophagus if we need to, through it's a balloon-based device, or focally with just kind of little strips that we can go systematically throughout the area that's affected. This treatment's highly effective, which is great. It has about 81% complete eradication at 12 months in high-grade dysplasia and 91% complete eradication in 12 months in low-grade dysplasia. Again, this is for non-nodular Barrett's, so you can't just zap something that's already grown into something, but if it hasn't, good news for patients. Okay, so this is what we use at this facility specifically for RFA. We use a standard upper scope, and then we have this little energy generator. It's not that little. And then our RFA catheter. We have different sizes, different shapes. Like I said, there's the balloon. This is the part that goes in contact with the mucosa. We have different lengths, different sizes, and that is decided by the provider. The way they decide that is the extension of the Barrett's, how many times it's been treated before, etc. Okay, and so here's kind of a graphic of what RFA looks like. So first is this balloon for the circumferential. So it goes down as a small catheter, and then we inflate the balloon, and then we can ablate 360. We don't use that as commonly. More commonly, we have, in this facility, we'll use the focal ablation device, which is the one I was talking about. It looks like a little baseball cap when it goes on the scope. And then we'll apply direct contact to the mucosa. And usually, again, depending on the size and the energy that is being delivered. On this guy here, that'll tell you how many times you've ablated, the energy that you're using. It's this particular company, it defaults to settings per catheter, which is nice, so you don't have to think about it. All righty. So we got a little video here. And I'm gonna fast forward through some of these videos a little bit just because I wanna like show you the point of it all, but we don't need to sit here and watch the whole thing. So maybe. We'll come back. All righty. So some nursing considerations for, okay. Nursing considerations for RFA. In procedure, something that's important so that we can have good contact with the skin is to avoid excessive moisture. So for these procedures, we do not use like the normal water-based lubricant that we use in pretty much every procedure. You'll see, I think in that video, if we can get it to work, Dr. Wani dipped the scope in water first. So there is some lubrication, but usually either the tech or the anesthesia provider will kind of help with the jaw thrust to get it down because it is like this baseball cap looking thing on the end of the scope. And then always be mindful of the processor and alert the scoping physician. So again, the processor that we use in this facility, it'll say how much energy is delivered. And, that can vary based on a few things. If there's a bunch of tissue sloughing off, if the catheter is getting dirty, if, this is a teaching hospital. So if it's a newer endoscopist that's working on things and, they're very focused on what they're doing, especially because you have to stay in the same position to zap more than once. So it's always helpful as a tech to kind of pay attention on that processor. It'll tell you, how much energy is being delivered. And so if you're consistently seeing like 50, 60, that means, it's not as effective. That, those numbers, that 81%, that 91%, that is with an effective delivery of RFA. So we want to make sure that that's, and, communicate it in a productive way. And then, so yeah, you'll document, in our facility, we've in the past documented our energy used and the number of ablations. Usually physicians want that number. And then mild throat pain can be anticipated. We usually advance diet as tolerated. I'm sorry, I forgot to write that in there. And again, this emphasis on the BID PPI therapy. And then if the patient's on anticoagulants, we'll have them resume per the physician recommendation. Okay. All right. We're just going to keep going. All right. So next we're going to talk about cryotherapy, which is really cool. That was a cold joke. Okay. This is where you laugh. Very funny. Okay. So cryotherapy is another option that we have to treat Barrett's. It's usually not the first line of defense. There are other interventions that have been in place. A lot of times, I just did one with Dr. Bilal yesterday. It'll be, the patient had a ESD prior, they're coming back, and we're just, trying to get that area as much as we can so nothing grows back. So it kind of works in two waves. So the first wave is it forms ice crystals by freezing water in intracellular, extracellular tissues, and that kills them immediately. So it's, it's like frostbite, tissue dies. And then the degree of cell death is compared from that just alone is comparable to RFA. And then that second wave is that cells that survive the direct injury die as a result of mitochondrial injury. There's a whole system of things that happened, but I figured that was a talk for another time. Okay, so there's two main forms of cryotherapy. This is kind of the older, more frequently used in the past. We still do it. Again, I just did it yesterday with Dr. Bilal. So we use liquid nitrogen. And so this is a contact-free, which is important to know. I'll tell you a little bit more about that in a moment as well. Hopefully I can get my other video to play. But so it's a low pressure spray of liquid nitrogen, which is delivered through a catheter of a therapeutic scope. Reaches a temperature of negative 196 degrees centigrade. And then the rapid drop in temperature is managed by venting the expanded nitrogen gas. So what happens, you've got your tank of liquid nitrogen, you're pumping it in, it's going through this catheter, you're spraying things, that's great, but then it is no longer liquid nitrogen, it turns into nitrogen gas. So the biggest thing with this procedure is we're making sure to vent the patient. So how do we do that? Again, this is what we use in our facility. This is our console. And you can see here, it's kind of zoomed in, that is where it's got its own built-in suction that comes in a kit. It comes like in a catheter. It's got a catheter and suction hookups that all fit in, as well as their own suction tanks. And so the way that we place that catheter is usually by taking a savory wire down the scope and then taking the scope off. You kind of saw Summer do something similar when we were placing the esophageal stent in that live case earlier. So as a tech, you'll hold and the scope will come off, and then we will feed the venting tube over that down to ensure that we're past the GE junction, because we don't want to be applying all that suction just like into the esophagus. And then we'll go back down with the scope. And this is a very dramatic picture of the catheter, but that's what's on the STERIS website. Okay, let's see if we can get this one to play. Maybe. Oh, that's a bummer. Well, this one is not a link. This one was like a video that was saved and then put on like a picture. Okay, we'll come back. Okay, so then we have our other type of cryotherapy, which is the cryoballoon. This is a newer therapy. It's pretty cool. Both the liquid nitrogen and the balloon have pros and cons. I think they both very much still have a place in the treatment of Barrett's esophagus. So the way this works is it ablates mucosa via direct contact, kind of. It's an inflated balloon that's filled with the nitrous oxide. So the balloon catheter is inserted through the working channel of a therapeutic scope. And then a canister with nitrous oxide is attached to an insufflation device, which is controlled by the scoping physician via foot pedal, which is a lot. Okay, so basically this is the canister. It looks quite big, but it goes on top of this guy right here. It'll screw in the top. And then you have your catheter there. It's a balloon. But I really wanted to show you kind of how it looks down here. So this is what you've got that you're going to be treating. And then you push the catheter out. This is with an inflated balloon. And you can kind of see in this photo, hopefully a little bit. It kind of reminds me of like a train whistle. There's like this little mouth on there. And with that foot pedal, the provider not only applies the sprays, but then also can move that little mouth up and down and around. And then this is post-treatment after healing. So immediately it doesn't look like that. The tissue can be ulcerated or frozen. That's more what we would look like. And so, yeah, this is more of like an intra-procedure situation. Okay, so nursing considerations for the liquid nitrogen. This is a big one. Ensure that the liquid nitrogen tank is full prior to procedure. We are very lucky. We work in a huge facility here. We pretty much like have everything available at our fingertips, which is super nice. But that's not the case for a lot of hospitals. And even here, sometimes, we can't always get liquid nitrogen because our main tank is not full. Our nurse navigators do a really good job of seeing these procedures, identifying, okay, this is a potential, and it's communicated through our nurse manager, our associate manager, and usually the day before, ideally, we will make sure that that tank is full. And then the other thing to know for the safety and efficacy of this intervention, the machine takes a decent amount of time to set up, and it is a lot of what it's doing is releasing pressure, and it's very loud. So I usually recommend setting it up. You won't not opening anything, but at least turning it on and letting it calibrate because it's very, very loud, and it can be kind of jarring to patients when you bring them in the room. And it's just kind of like these super loud spurts of, yeah. And then the other thing I kind of touched on this earlier is ensure the ventilation of gas is occurring throughout therapy. As a nurse, you're really going to want to assess before you get started with anything, make sure like the abdomen is soft. And during the procedure, again, be checking that the entire time. And then document, again, this is going to vary based on your facility, but how much you've used. And also with the liquid nitrogen, I won't get super, super into it, but there's, you will also document how many sites that you have applied the liquid nitrogen to. And this is an endoscopist thing, but the liquid nitrogen, we don't come into direct contact with the mucosa. Again, it gets super, super cold. And it's like that movie, A Christmas Story, where the kid gets stuck to the stuck to the telephone pole because he's licking it. So we don't want to do that. Sometimes it does happen, but we don't want to cause more tissue damage than than we're trying to do, like damage things that we're not trying to damage. And then for the cryo balloon, the assisting nurse will be holding that insufflation device. The device has a timer that counts down for each spray to ensure maximum effective therapy. You guys all got to meet Dr. Wani. He moves at 100 miles an hour at all times. And so it's nice to have a visual of like, you have 10 seconds, that way we all hold ourselves accountable and give the patient the best care. And then, especially for the cryo balloon, the spray catheter can be kinked and lose effectiveness. Same with the liquid nitrogen. So pay close attention to the physician and keep the catheter as straight as possible. Because again, even though that pedal can kind of move, that doesn't mean that, sometimes the doctor won't have to like change his position. And so just move with your physician, pay attention to what's happening in the room. Okay, and then our last two interventions, I'm going to go over these a little bit more briefly. So we have our endomucosal resection, which Marcy had a full talk on this morning. We do it a little differently for Barrett's esophagus, and we'll go into those differences. And then there's also endoscopic submucosal dissection. It's very similar to POEMS, not the same, but in the same genre. So this is for lesions that extend into the submucosa, but not the muscle layer. So again, if we think back to that picture of the ultrasound, if the physician sees that it's penetrating into the muscle layer, unfortunately, like that needs to be surgically resected. And so EMR, the tissue is removed via cautery and a snare, like we saw earlier. So there's the lift and cut method, which is what Dr. Muthing was doing, and that's what Marcy went over. And that's an agent injected into that submucosa and then resected with a snare. And then there's the ligate and cut, which is the main thing that we do here. And the tissue is banded with an over-the-scope litigation device and then resected with a snare. So I'm sure a lot of you most of you have experience with banding esophageal varices. It's like that, but we're not banding and cutting off varices. But it's very similar device. You get the rubber band around the tissue after sucking it up into the scope, and then you snare it off. And then our ESD, the target lesion is removed using a specialized endoscopic knife by dissecting through the submucosa. So similar to POEM in the fact that you're going underneath and you're cutting with the knife injects as well, but instead of going past the submucosa into the muscle layer, you're not doing that. You're just cutting under the lesion and lifting it off. All right, so I have some photos here. And so this is some nodular tissue. You can see how it's like bumpy here. So that's not something that we could RFA. And then it's very common for providers to first use some soft coagulation to mark where they're going to be resecting. Because once you get started, especially with this cap, you can kind of see it definitely affects like your field of view. You want to make sure you're getting the extent of everything and you know where you're at. It's like a bookmark. And so this is the cap on. And in this, the provider is sucking up the mucosa. Ideally, you want to have a red out similar to varices, and then you deploy the band, which is figure D. And then figure E, it's kind of hard to see in that photo, but that little white, this right here is a snare. And so then you'll close and use cautery. This is a situation where you definitely want to be in communication with your provider and how your snare feels when you close. If it's super bouncy or it feels like you have too much, that's always something to communicate. This device is very effective in separating the mucosa from the muscle layer, but we always want to proceed with caution. And then this is what it looks like after we have resected that bite. And then as far as ESD goes, this is illustrated, but it's a pretty good indicator. So this is the area that we're going to be taking off. ESD is nice because you take the entire lesion and then you can ensure that you have negative margins, very low likelihood of that lesion returning. And this is what it looks like after an ESD so that you can see that entire area was taken off. I wish it happened that quickly. Usually those procedures are very long, a couple hours. All right, so I have a picture here of what the outside of all of that looks like. So you'll have your band litigation kit. Again, it is just like kind of like this little crank device. There's different brands. It looks similar to the over-the-scope Ovesco that Dr. Wani used earlier. And then you have a snare. It's a hexagonal snare that comes with the kit, and that's what you use to resect. And then for your ESD, it's kind of hard to say like exactly what you'll need. Very similar to POEM in that you'll have this specialized knife. Usually the knife has the option of injecting fluid. And then so you'll still need cautery and a lifting agent, very physician preferred. And additionally, if you're ESDing, something in the esophagus, you may need a different tool than if you're doing something that's like going through the GEJ to the cardia. The last thing I wanted to say about those two is post-procedure, especially depending on the extent of the resection or dissection, patients do run, there is a risk of that kind of scarring down and patients developing a stricture. And so that is unfortunately an expected finding, but they just come back and we do some dilations, usually inject some Kenalog, and they do pretty well. Sometimes they have to come back a couple times. Yes. Between the band and the area cut out already between the band and the which band and mucosa. Yeah. Every once in a while, like correct. Yeah, that's not a stupid question at all. That's a very good question. Yeah. Yeah. All righty. Okay. See if none of the other video I have is working, guys, I promise. So let me, I have an ESD video I'm going to show you here. Where did it go? Oh gosh. Okay. All right. So you'll I'm going to go ahead and play this. So you can see this lesion right here. Oh, where's my thing? And the physician has marked this lesion. That's what you see those cautery marks are. This is kind of hard to tell, but right now this is the submucosal dissection. You saw they just injected into the submucosa. We always use blue, and it just, again, helps us stay away from that muscle layer. Things get really topsy-turvy and hard to see when you're doing ESDs in the esophagus. So what you're looking at here is we're cutting through, so that's the other side of the lesion. So he has tunneled under and is cutting through the other side. And you can, I don't know if you appreciated this, but you can see that different types of knives have been used during this. And again, it's just like how long they are, how like the shape of them, those are the things that we're looking at. So we're close to separating the lesion from the esophagus at this point. And sucked it up. So at this point, what they're doing is using a coag grasper to cauterize some vessels that were exposed just to reduce the risk of bleeding. And you can see all of the resected tissue underneath there. Back to my PowerPoint. All right, so nursing considerations. Where is my... you want to note your cautery settings. We use Irby for our
Michael,
cautery
the
here.
first video.
Thanks, Jacques. So, Jacques, this is an 85-year-old medical professional.
Oh, this is just autoplay. Okay, thank you. Oh, okay. Note your cautery settings. Again, we work in a big facility. We're very spoiled here. We have all of our pre-settings on our devices, but I still always double check with the physician. Hey, is this what you want? Especially on IRBs, there's different settings for incisions, for tunneling, if we're using the tip of the snare to coagulate something, if we're using the coag grasper. And it varies from procedure to procedure. And then communicate throughout the procedure. I feel like we talked about this a lot with Dr. Muthing and with Marcy this morning about like a closed loop of I am closing this snare after, the MD says I'm closed snare, I am closing this snare. How does it feel? It feels like this. Especially again, sometimes with that cap, you have poor visualization. And so, we're used to doing a quick colon and taking off like a 2 millimeter polyp, like they can see that the snare is closed and you're ready to go. But not always in these situations. And so it's very, very good to have that closed loop of communication. Again, be mindful of space, equipment, and cautery. It's always good to have if you're able to in your facility, it's always good to have a backup scope. If you're doing an EMR like this, just out in the hallway or somewhere that you can run and grab it if you need to do something quickly, because it's not as easy to throw tools down. And it's sometimes nice to have another scope that you can plug in and go if you need a cap or things like that. And then that way, because if you take that litigation device off, you can't put it back on. So, and then for ESD, similar to with the cryo, you always want to perform a baseline intra-procedure and post-procedure assessment. We are going into third space, the submucosa, not never land, but with that, there's always a risk of perforation. So we just want to make sure baseline that the abdomen is soft or how soft it is. Some people, baseline aren't very soft. And so that way, where you're coming from if you have concerns about that. And additionally, in the neck, it's also good to feel the neck, any signs of crepitus, that sort of thing. Again, that would be a sign that CO2 is going where it's not supposed to be going. And then I always just for these procedures, our patients are intubated. Our anesthesia carts that we have in our rooms will let you know the peak pressures. So that is something I always just kind of glance at to see that it's staying stable-ish throughout the procedure. And then they also talked about this in the poem earlier. Note the level of insufflation. Does the provider want to be on ultra low or low? Especially in the esophagus, you guys saw how confusing that video is. Like, what is up? What is down? Where am I? So sometimes they'll have you turn up the insufflation for a second just so they can kind of get their bearings again. But it's always good to, ask, hey, do you still want to be on medium CO2? And then typically we pin these specimens just to take pictures and then also get a bearing and look at the edges of the lesion, because ideally you want to take off more than the lesion so you have negative margins and that it does not return. All right, there are my sources. I apologize about the videos. I don't know if we're going to be able to get them to play, but do we have any questions? Yeah. Oh, the mics are off. Yeah, sorry. No, you can turn it on. It's just the thingy.
Patient that has a pretty decent prenatal hernia on PPI, do you think they would automatically go on PPI to Barrett's from happening?
That's a great question.
Dr. Wani, where are you?
Yeah, that's it. Oh, we also have one of our fabulous physician's assistants here. Do you have any idea? Okay. That makes sense. Yeah. If they're symptomatic. All righty. Well, speaking of our fabulous PAs, we have Colette Crane coming up. Oh, sorry. Oh, I'm sorry. I didn't see ya. Of course. You can ask 3. Yes. That's a good question. I believe that Dr. Wani prefers the balloon at this point. It just logistically is a lot easier to achieve. That is one, but also what was I trying to say? Where's my train of thought? It's just as effective, right? And so I think it's provider preference a lot more than anything because they have pretty much the same efficacy. And I can send you some articles if you want. There's been a few reviews. So yeah. Yeah, thanks. Okay. All right. And this is Colette Crane. She is one of the physician's assistants that works with the therapeutic team. They are the reason that we run as well as we do. They field so many things that we never even have to see or deal with. And we are so appreciative. And so Colette is going to talk about EUS and ERCP. Yep.
So just double click on this little buddy. Oh, great. Oh, there's someone who helps. Fabulous. Mm-hmm. Okay. Hi, my name's Colette Crane. I'm one of the physician assistants here. I work in particularly the inpatient GI setting, just on the therapeutic side. So between myself, you may have seen Caitlin sitting down there in front with me, and Katie, there are 3 of us. And essentially our role is to run around the hospital, see people that have anything GI therapeutic related, work them up, see what their symptoms are, and then see if they need a procedure from our team. We staff it with our providers and then we get them teed up for procedure. So today, I'm going to talk to you about the pancreas. I'm going to kind of keep it simple
everything that the pancreas does, and then the complications of the pancreas, and then how we can treat it. I want to go over a little bit about the anatomy of the pancreas, its pathology, how it works, understand when we need to go in and do something, and then we'll talk a little bit about evolving techniques and tools that you guys as the nursing team end up using, which I'm not as versed with, obviously. It's pretty amazing what all of the nurses do for all of these endoscopic procedures. It's pretty amazing. A lot of these patients would end up being surgical candidates or having to go into surgery if we didn't have the ability to do this endoscopically. So it's pretty remarkable. So the pancreas, this little guy, this little S-shaped organ, it's a retroperitoneal abdominal organ. That means it sits way, way back. So it's at the level of like the kidneys. So a lot of times patients with any sort of pancreatic etiology will complain of, I don't know what it is, I'm just having severe back pain. Or I feel like I'm going to get a UTI like I usually do. That's kind of how far back it sits. The pancreas is a really cool organ because it does two things. It's an exocrine organ, meaning that it releases all of these pancreatic juices into a duct, but then it also releases a bunch of hormones into the bloodstream. Okay, so some of the enzymes you probably know about is lipase. That works with your bile from your gallbladder. That's going to break down your fats. Then you have proteases. Those are going to break down your proteins. Then you have your amylase, which is going to break down like your carbohydrates, and then just a little bit of bicarb to make sure it's not so acidic. The endocrine portion is going to be all your hormones that are released in the bloodstream. So that's going to be like your insulin, your glucagon, or your somatostatin, the thing that kind of calms everything down. So cool organ. All right, 3 things I want to talk to you about anatomy. First, in this first slide, I just want you to see that kind of where the pancreas is located. So it's sandwiched between the stomach and this first part. Does my arrow? Oh, I have to use this. Oh. What do I do? Press it up here? But then I like can't see. You just leaned over it? Okay. So just appreciate the fact that it's sandwiched between the stomach and the small bowel, okay? This picture here is the endoscopic procedures that we do. Here you can appreciate that the pancreas is behind everybody. So the scope is gonna go down the throat into the stomach and then into this first part of the small bowel. Once you get to that point, then we can access whatever we need into the pancreas, okay? So it's not a far traveling job. Next thing about the anatomy is I want to talk about the ducts. So this picture here makes up the ducts of the pancreas. That is 90% of all of our anatomy. Okay, there are congenital problems and other things that can happen while you're being born that can mess up the ducts, but this is 90%. This is all you need to know for the talk that I'm going to talk about today. So there's a main duct. This is the guy that's able to release pancreatic juices from the tail all the way down to the small bowel. Okay, this is called the duct of Wirsung. It's the main pancreatic duct. And then the little nubbin duct here that's above it is called the duct of Santorini. This is the minor duct, and it releases pancreatic juices just from the head of the pancreas instead of the entirety of it. Okay, juices that release out of the top here, this is called the minor papilla. And then the juices that are released out of here is called the major papilla, or sometimes we call it the ampulla of Vater. This one is where we do all of our endoscopic procedures for the sake of this talk. And this is important to recognize because that duct comes down and meets with the bile duct, which is seen in green in this picture. And so bile and pancreatic juices meet each other. And this is where they're emptied into the small bowel. Okay, so here, those ducts we're going to use kind of for this talk today. Third thing about anatomy is just the blood flow. So you have your aorta and your portal vein. These are big blood suppliers. It splits off into the celiac artery, which is this little guy here that splits off into your gastroduodenal artery, which gives blood supply to the head of the pancreas and the uncinate. And then it splits off to the splenic artery, which is going to feed the body of the pancreas and the tail of the pancreas. This is important for procedures we start to talk about a little bit later on because often there is a risk of bleeding as we start poking around here, okay? So 3 things I want to talk about today: acute pancreatitis, chronic pancreatitis, pancreatic cancers and cysts, and then how we work them up, and then what we do endoscopically to treat them. So let's start with acute pancreatitis. What is acute pancreatitis? So something you did is going to acutely injure the pancreas. The next slide, I'll show you what those things are. But the pancreas is a very moody individual. You put something in your body, you drink a bunch of alcohol, you upset it. Now the cells of the pancreas and the duct of the pancreas get so angry that they start to get leaky with all of these enzymes that they typically redirect to the small bowel, okay? You can imagine a bunch of enzymes outside of an organ or a duct is going to cause a lot of pain, okay? And in order to say, hey, you have acute pancreatitis, you have to have 2 of these 3 things, okay? So when you go to see a patient, either they're in severe epigastric pain and or a serum lipase of 3 times upper limit of normal, right? So that lipase should be going down into the small bowel to help you digest. But in this case, it's in the bloodstream, so it's leaked out. So it should be very, very high. Or you got a CT scan or imaging that shows a lot of inflammation in the pancreas. So 2 of those things. Here are some causes. 80% of acute pancreatitis is caused by alcohol. That's a lot. So when someone comes in with a acute cause of pancreatitis, the number 1 question you should be asking is, how much do you drink? Endoscopic procedures that we do can give you pancreatitis. Autoimmune problems, genetic problems, we usually see pancreatitis in people under the age of 21 for this. Anatomical variants of the duct. Remember, I told you what it should look like, but it can get messed up. Certain medications, cancer of the pancreas, oddly, a scorpion bite. Trauma, we've had a couple bulls hit someone in the left side of the abdomen. That'll really tick off the pancreas. Or idiopathic, we have absolutely no idea what's going on with you. Okay, so if you're diagnosed with pancreatitis, God help us all, hopefully it's short-lived, meaning that you get it, the pancreas got super inflamed and angry, I give you fluids, I give you pain meds, you're out the door. If you get a complication, 2 complications I'm going to talk to you about are these pseudocysts and these pancreatic duct leaks, it's a problem and we probably need to intervene. People who get acute pancreatitis, 20% of them are going to get one of these complications. And if you get a complication, your mortality rate is upwards of 20 to 30%. So it's important to intervene quickly, to recognize it, and to be at a facility that has the ability to intervene. First one let's talk about is pancreatic pseudocysts. So this is a CT. This is huge. If you can imagine this being the bottom of your abdomen here, liver up here, stomach up here. This is a collection that is taking up the majority of your abdomen here. This is a pancreatic pseudocyst. Okay, so you got acute pancreatitis, you leak some fluids, but instead of the body kind of healing itself, the body created a inflammatory cascade that pulled in water with it in order to create some sort of healing. But as an effect, you got this collection. Okay. And they can be big or small. This one is just, I'm exaggerating it for you. And the interesting thing about pancreatic pseudocysts is that they always make a wall around them. It's just the way that they act. So the body kind of panics with all of this fluid and it's going to create a fibrous wall or a scarring down of this collection in an effort to try to heal it. Okay. And you can appreciate that in the white. That's the wall that's starting to form around it. And this is just kind of an anatomy piece of the wall being made. I'm going to talk about some cysts later on. So this is what is very unique about pancreatic pseudocysts. So when do you know to do something with these patients? It's all based on symptoms. Okay. Some pseudocysts will heal on their own. The body will do a good job. It'll wall it off. It'll start to reabsorb. But there are times when patients get very, very ill, either pain, nausea, vomiting, early satiety where you munch on a cracker and you just feel really, really full, or this collection starts to get infected. So we only intervene when you start to have those symptoms.
Keep in mind that these collections have to create that wall for us to go poke them. And I have a couple other pictures that may be more helpful for you to see, but it must have that wall around them in order for us to all endoscopically intervene. Okay. Typically, cysts greater than 5 to 6 centimeters are probably going to cause symptoms because it's right by that tummy and small bowel. But size alone does not determine whether or not we go in and poke this thing. So how do we poke it? We do it with what's called an endoscopic ultrasound, which is a scope that at the end of it has an ultrasound probe. Okay. And it is able to deploy a stent across the stomach wall into the collection to help the collection start to decompress. Okay. Picture here. This is the scope. This is not an ultrasound. But this is the stent that's going to be deployed across the stomach wall into the cyst. And there it is. And then this is a CT scan. So if you can appreciate, the stomach is up here. You deploy this weird looking, barbell kind of stent here. And then this is the collection all the way down in the pelvis. Consider the liver up here. So it's pretty huge. And so this stent is now going to allow all of this collection to start to drain through the stomach. And so the whole thing's going to start to decompress and go away. And that'll relieve symptoms quickly. Here's another picture. Here's an actual EUS picture. So this is what the docs and you guys as nurses will see. Stomach's over here. And then this is identifying the actual cyst. It's dark black. And then once you deploy that metal stent, brown murky gunk comes out. That's pretty pathognomonic for a pseudocyst. And then the picture on the right is looking you're in the stomach and you're looking at the stent. They happen to place another little plastic stent through that just to help overall with draining. Okay. These stents dwell for about 4 weeks. That's how long it takes for this thing to drain. And sometimes we have to go back in and manually start to clean out very, very large collections, okay? After about 3 to 4 weeks, we'll get a CT scan and start to see if that collection is starting to get smaller and smaller and smaller. And then we remove everything. And most patients go back to their normal life. Keep in mind, this is a big stent. So those arteries we talked about in the beginning, there is about a 10 to 15% chance of bleeding in deployment of these stents. And that is actually considered a moderate to high risk for this procedure. Okay, next complication of acute pancreatitis, we're going to talk about duct leaks. So you've gotten acute pancreatitis, bunch of garbage is leaked out, but now your pancreatitis was so severe that the pancreatic juices are now actually starting to leak outside the wrong way. So instead of going down this way into the small bowel, this is our scope here. Instead of going down the small bowel to help you digest, it's leaking out the back end. Remember, these are enzymes, so it's extremely painful. Pancreatic duct leaks are strongly correlated with disease severity, meaning the worse your pancreatitis is, the more likely you're going to have a pancreatic duct leak. And in acute pancreatitis, it typically happens in about 3 to 38% of patients. This can also happen in chronic pancreatitis, although the incidence of this happening is less known. So they kind of give you a range of about 10 to 20% where you get this leak. So you're gonna require intervention on these duct leaks if you have symptoms similar to our pseudocysts. So try to imagine all of those enzymes are leaking out the backside. So you're gonna get pancreatic ascites, meaning you're gonna kind of fill up with all of these juices. You're gonna start to have abdominal pain. Sometimes the body gets real ticked off that there's fluid within the abdomen. So it visualizes all of those juices up to the lung in an effort to find a way to get this stuff out of there. And then sometimes it just all gets infected. We treat this by doing an ERCP. So we haven't talked about this yet, but an ERCP stands for an endoscopic retrograde cholangiopancreatography. Big word for us going in backwards into the pancreas, hence the retrograde part. Cholangio stands for biliary tree, which we can go into too, or pancreatography, meaning we're going into the pancreas, but we're going the backwards way of the way the enzymes run. This is a great way for us to identify the duct and then use contrast dye to identify strictures, stones, and masses. So for a pancreatic duct leak, we're going to do an ERCP. So we're going to get down into that first part of the small bowel. And the goal here is to place a stent, a plastic stent. They're small. The whole goal of this is to divert those pancreatic juices the right direction and allow that end tail of the pancreas to heal. Stenting and ERCPing with pancreatic duct leaks has an 80% success rate. So this is kind of a sequence of an ERCP very quickly in 4 photos. Here's your major papilla. Remember, that's that major duct that combines with the bile duct. So I know I'm at that major papilla because I see bile coming out. So I know that if I can get in here and go that way, I'll be into the pancreas, okay? Then we get a wire in there, we shoot some contrast, and we identify the leak, which you can kind of see right there. After the procedure, this is a little plastic stent sticking out into the small bowel, okay, helping everything run the right direction. Yeah. That's a great question. Both. Oh, full, I'm sorry. So that's acute pancreatitis. Those are 2 big complications and then how we can treat them. So now I'll talk to you a little bit about chronic pancreatitis, and what we do for them. So chronic pancreatitis, as you can probably imagine, is acute pancreatitis, but it really never goes away, or it keeps coming back over and over again. It's repeated injury to the pancreas over time. It causes a progressive fibroinflammatory process. What does that mean? It just essentially means a bunch of scarring down and thickening of the tissue and ducts of the pancreas. The most common causes of chronic pancreatitis is tobacco use and ongoing alcohol use. I should probably also mention, so while you're scarring down the pancreas over time, you're going to start to lose that ability to release enzymes into ducts. And then you're also going to lose that ability to release hormones into the bloodstream. So you can kind of imagine where we're going with that, but it can be very detrimental. So 2 big things that we can take care of endoscopically for chronic pancreatitis are going to be ductal changes, meaning that this ongoing scarring down of the pancreas has now affected the duct of the pancreas, so much so that it has caused a stricture, meaning like a narrowing or kind of a beating of the duct. And then like we talked about earlier on acute pancreatitis, it can also cause a duct leak where it goes the other way. The other complication is stones, stones primarily in the duct. And then I didn't put this in red, but this is another complication of chronic pancreatitis, which is ongoing pain that is going to require opioids for the rest of your life, maldigestion, because you've destroyed a working portion of the pancreas. So you're eating and it's really not getting reabsorbed. And then diabetes, because you're starting to destroy that endocrine portion that releases the insulin. Endoscopically, not much we can do about that. So let's talk about ductal changes, these strictures. So in this picture here, you can kind of appreciate that the duct itself is not really nice and smooth. Hence, because it's been injured so many times, it kind of starts to scar down. Picture all the way on the left is the goal of what we're going to do here, which is to place a stent in here, similar to what we did for duct leaks. So we do this with an ERCP. Okay, so we go in there, we access the major papilla. We do a sphincterotomy, which I haven't talked about, but that is the opening up of that major papilla so we can get ourselves in there. And then we're going to place a stent. The difference here compared to what we were doing for duct leaks is that this is a prolonged approach. So this duct is messed up. So we're going to put a stent in it to help it relax a little bit. And then over 6 to 12 months, you're going to start to increase that stent so that you can start to get remodeling of that duct so that it's nice and normal. This approach gives pain relief to patients up to 85% of them. Some evolving techniques that we don't particularly use here, but some things that are kind of up and coming is putting in a fully covered metal stent. So far we've talked about these little nubbin stents that are tiny, but the idea is that maybe you could use a really big stent. See how big that is compared to this one? Put it into the pancreatic duct stent, leave it in for a couple months and be done. So that way the patient wouldn't have to come back for 12 months and keep upsizing it. The problem is these have horrible adverse events. These stents move, the big ones, and then they also block the bile duct because remember that can come right off of the pancreatic duct. So, but some emerging ideas. Here's the procedure in terms of a cholangiogram. So when we go in to do an ERCP, we're shooting a bunch of contrast into the duct. So here's a gallbladder, it fills up really nice. And then the gallbladder releases out of the common bile duct, and then it merges with the pancreatic duct. The pancreatic duct, this should be a nice smooth duct, just like this, but you can see these strictures and these intermittent narrowings. So we're identifying a stricture, and there's a really nice one too, okay? Here you can see the fibrosis and then stent placement. So 6 to 12 months, hopefully we can get that back and running. I already talked about that. Oh no, this is my calcifications. Okay, so now let's talk about stones with chronic pancreatitis. So when you have repeated injury of the pancreas, not only does it affect the duct, but it affects the enzymes that want to release out of it. So when all the enzymes go to get out of the pancreatic duct, if they aren't moving as quickly as they should, and they kind of start to slow down because of that stricture, you're going to start to get stasis of the secretions and essentially a protein plug. That protein plug over time will become a calcified stone in the duct, okay? You also can get stones in the parenchyma of the pancreas, meaning the tissue of the pancreas, for the same idea. Those cells are also trying to release a bunch of enzymes and hormones, but everything is slowed down when everything's so scarred down, so then you get stones. If you see any kind of stone on a CT scan, that is like hallmark chronic pancreatitis. You see these little stones sitting around in the pancreas, you know this patient has chronic pancreatitis. They've had repeated injury to their pancreas. Two different pictures. So keep in mind that if you have stones in the tissue of the pancreas, we can't do anything about that. I can't get there. I can't pick out all of those stones. So the only thing endoscopically that we're working on is stones that are in the duct. And we know when they're in the duct, when we see dilation upstream from the stone, if you can appreciate that. I mean, this is a whopping stone. But look at the duct is pretty big, that dark area. That duct's responding, it's freaking out, it can't get its enzymes out. So it's getting bigger and bigger in an effort to help itself. That we can work on. This, I don't know what's going on. There's stones freaking everywhere, right? I don't know what's in the duct. I don't know what's in the tissue. There's just a lot of them. All I really know at this point is that the patient has chronic pancreatitis, probably from smoking or drinking. And either I will be able to help them with an ERCP and stenting, or I'm not. And this is going to be lifelong chronic pain management and no alcohol, no smoking, not even for a birthday. Okay. So when I talk about stones, I'm talking about ductal stones because these are the ones we can go get, okay? And it all depends on size. So stones that are Inselsteins, tiny, less than 5 millimeters, we're gonna go get them with an ERCP. And I'll show you a picture of that. Kind of what we've been talking about. Get down to that major papilla, open it up with a sphincterotomy, dilate the duct, go in there, get some stones out. Okay. Large stones, kind of like the one I just showed you, is going to require breaking them down into tiny pieces and then going in and getting them out. So small stones, we've been talking about ERCPs. Here's kind of a sequential process of it. One, find that major papilla. This one doesn't have the nice bile coming out of it, but identify it. fillet that little sucker open so that we can get all of our scopes and wires in there. And then deploy a balloon starting at the tail of the pancreas all the way down, and you start sweeping out these little buddies. Okay. A final cholangiogram or a contrast study will show that you've gotten majority of the stones out. Okay. Now, if you continue to drink and smoke, this may continue to happen over and over again. But hopefully this is a one and done. Large stones over 5 millimeters are going to require a couple things. So right now, guidelines are showing that the first thing we should start with is S-wall. We have some studies here at UC Health that we're kind of trying to figure out what's the best move. But right now, if you got a big stone, we're going to try to break it up first. We do this with S-wall. It's called extracorporeal shockwave lithotripsy. Extracorporeal just means outside the body. So all we're doing is trying to break up the stones from outside the body. So the patient lays down, this little shockwave therapy targets the stone in the pancreatic duct, bang, bang, bang. Hopefully it breaks up. This is a before and after. These are really hard to kind of appreciate, but the darker area on the x-ray are stones. And then after S-wall or the shockwave therapy, you see a lot less of it, okay? People who receive S-wall achieve over 90% of fragmentation of these stones. So that's pretty darn good. And then after you fragment them with S-wall, you still have to go in and get them out. So by way of ERCP. So let's say either at your facility, you don't have S-wall to do the outside shockwave therapy, or let's say you did S-wall, but the stones didn't break up as much as you thought. Another option is to do pancreatoscopy. So this is an endoscopic procedure similar to an ERCP, but it's using a specific scope. This specific scope is able to not only look at the ductal mucosa, meaning the actual inside of the duct. That's not something we've done thus far. We can identify the stone and start shooting with some shockwave therapy, and then we can break it up into tiny little pieces. And again, just like the other one, we're going to have to do an ERCP to sweep everybody out. Success rate here on pancreatoscopy is just a little bit littler at about 88%. All right. Last but not least, I want to talk about pancreatic cancers and pancreatic cysts and what we do for them. So pancreatic cancers have a horrible mortality, morbidity rate. So it's important to get these sampled as quickly as possible. The most common pancreatic cancer is called pancreatic adenocarcinoma, and it makes up 85% of our cancers, our pancreatic cancers. Here's a CT scan. Pancreatic cancers are hard because they're not well defined on CT. So it's very hazy. I don't know what's going on, but it doesn't look right kind of thing. It's hazy. It's not well defined. It doesn't have a wall. Okay. Over here is going to be a cyst. A cyst, a little more well defined, and it has an obstructive component, meaning you can see that upstream pancreatic ductal dilation. So cysts, it can be confusing. So we talked about pancreatic pseudocysts. Cysts are a group of cysts that are made from abnormal cells. We can't really pinpoint why or how, but the cells are not normal. And they create these cysts. All pancreatic cysts have a malignant potential, meaning that the cells are just not normal. So as they start to divide, they're not going to do normal things. So every one of the pancreatic cysts can become cancer. These two I've listed here are the highest rate of pancreatic cancer. Intraductal papillary mucinous neoplasms, these are cysts that release mucin, have the highest chance of becoming cancer, upwards to 38 to 85%. Mucinous cystic neoplasms, more commonly in women, their chance of malignancy is anywhere from 10 to 34%. So if you identify a cyst or you don't know what it is you're seeing, we need to sample it. Big table that I'm not going to go through, but this is a list of our pancreatic cysts. They all have different distinguishable features to them. They all have different malignant potential, and they're all just a little bit different. Okay. You can see up on top, pancreatic pseudocyst that we talked first has a 0% chance of malignancy. So that's the biggest difference. Keep in mind also with pancreatic cysts, they don't create the wall around them, similar to the pseudocysts that we saw. And sometimes you can appreciate that on CT. Regardless, these need to be sampled because of their risk. So how do we sample them? So similar to the way we got into a pancreatic pseudocyst by EUS, we're going to do that for sampling here. An EUS is minimally invasive. It uses high frequency ultrasound in order to sit on the edge of the stomach and view the pancreas in order to see how big everything is and if there's anything we can biopsy. EUS is really great because it also allows you to see surrounding features too, like lymph nodes, spleen, liver. EUS is superior to CT or MRI. So if you get a CT, something looks questionable, it's reasonable to move on to an EUS. There's a couple different ways we can sample these suckers. So we can do it with FNA, which is a fine needle aspirate. This is for solid and cystic tumors, solid like our actual pancreatic adenocarcinoma. And the nice thing about needle aspiration is you can take cells for cytology, fluid analysis, and DNA testing. And then some oncologists will want an FNB, which is a fine needle biopsy. It's just a bigger needle. But this allows us to get a core biopsy to send for immunochemistries, molecular testing, or any type of subtyping so that they can do direct therapy for these types of patients. Here's a picture. So ultrasound, right? Stomach over here, you're going to identify the cyst, which is this darker area here. Once you identify it, then you're going to inject one of whatever needle you're using, an FNA, FNB, in order to grab a sample. Okay. And then here's kind of an animated picture too of grabbing samples. And there's different needles you can use. Keep in mind the needle all the way to your left is an FNA, and then all the needles afterwards are FMBs. There's this evolving technique for tumors and for cysts, particularly mucinous cysts. Remember, those had like the 38% risk of malignancy, where we use an EUS scope and we're going to directly inject a chemotherapeutic agent into the cyst. The goal of this is to induce local destruction or cyst breakdown so that hopefully the cyst goes away or it reduces in size. To a point that if it were a tumor, it could be surgically removed. Okay. All right. Finishing up here. I know it's been a long day for you guys. So this is the last thing I want to talk about is pain management and what we can do for it in the endoscopic world. So as you can kind of imagine, in all of these things that happen to the pancreas, a lot of patients have pain. So our team can offer EUS guided celiac plexus blocks. We only use them for patients with chronic panc or pancreatic cancer. Okay. This is a minimally invasive procedure, just like all of our EUSs, that uses a local anesthetic, or you could even use a steroid. And you're going to bathe the nerves that shoot a message from the pancreas up to the brain that you are in pain. This is not permanent, but this allows for patients to decrease their opioid use and have less pain overall, a better quality of life. So what is an EUS celiac plexus block? So we talked about the blood flow to the pancreas, the celiac artery being the first little nubbin that came off of the aorta here. So that celiac artery is surrounded by nerves. Those nerves are a plexus that then innervate all of the abdominal organs. So, sorry, I keep touching that. So one of the the celiac plexus that comes off of the artery is sending signals to the pancreas and to the stomach. Our goal here in this procedure is to bathe that plexus of nerves with an anesthetic to stop the pain. Celiac plexus blocks are pretty successful in pain. They work best with pancreatic cancer, and I don't really have a reason behind that, but they get the most pain relief with a EUS celiac plexus block. Obviously, you're shooting lidocaine or corticosteroids into your abdomen. So if it's picked up by the blood, you may have diarrhea or hypotension from that. Very mild adverse events. We're near an artery, a big artery. So obviously one of the risks of this procedure would be bleeding. Here it is again. So celiac artery, that's in red, comes off of the aorta like we're talking about. Celiac artery here comes off, right there to the aorta. We know around here somewhere is the plexus block. You don't see that in the ultrasound, but we know that if the artery is here and the nerves are in yellow, we know they're intimately that close to the artery. So take your EUS scope down, bathe that area with something to numb it up, and get the patient some pain relief. I'm just showing this picture here on the right because a lot of institutions don't offer EUS celiac plexus blocks. And so you may be familiar with percutaneous celiac plexus blocks where they can go through the back and inject with pain relief. This is preferred. It's less risky, but just kind of wanted to put this on your radar. Some patients may tell you that, or some institutions only do those. If you get pain relief from the lidocaine or the corticosteroid we put on there, we have something called a radiofrequency ablation. Lula talked a little bit about it for Barrett's. This is different, but it's still using that radiofrequency energy. And the goal here is to ablate that plexus of nerves. Again, it's not permanent, but it will give you a longer relief of pain if you got relief from the first one, from the celiac plexus block with lidocaine or steroids. Okay, it's superior to the other one. Okay, so that's everything. So we talked about endoscopically how you can intervene on acute pancreatitis, chronic pancreatitis, and tumors and/or cysts, and how we can do it endoscopically. That is everything. Thank you. Oh.
I just wanted to confirm, you were saying if the chemical like worked, then you would go into ablate it versus if it didn't work.
So if patients do not get relief with steroids or lidocaine in that area, we do not move on to a radiofrequency ablation. So kind of start out simple. If targeting that nerve made a difference for you, then heck, let's go burn it, kind of thing. Don't burn it first. Yeah. Yeah. We're always told to get lots of fluids to these patients. What do fluids do for them? Like, why is that helping you? For which one? For the. Yeah. Great question. So when you have acute pancreatitis, or let's say we're afraid you're going to get acute pancreatitis, remember acute pancreatitis is that massive release of enzymes. And all those enzymes that are released from the pancreas are going to pull water from your body. And so the goal outside of the organs, like in my stomach or in my abdominal cavity. So if I can flood IV with fluid, then it balances out. It's an osmotic effect, if that makes sense. So your body, if it gets acute pancreatitis, is going to flood all of this liquid to this injury in the pancreas. But if my veins and arteries are full of water, it'll start to pull it back into the arteries and veins. Does that make sense? So then maybe you just get acute pancreatitis, meaning like, oh, I had a little pain, but instead I don't get this massive pseudocyst, right? Because I have a ton of water in my fluid or in my veins. So it's equal. The body's not going to be pulling water out. Yes. Yeah. Yeah. comments, you pull it out, is that tissue gonna be like flexible now, or is it still scarred, but it's like not as bumpy, and that's the goal? So the goal is to actually remodel the duct, so it will actually look better. Now, we don't usually do pancreatoscopy, meaning I'm not gonna actually see the mucosal of the duct. But by way of how smooth it will become, I can make the assumption that it has healed. There may be some scar tissue above, but it's not causing extrinsic compression anymore, if you know what I mean. Yeah. That's a great question. So bigger stents in anything, biliary tree or pancreatic duct, does have the risk of causing obstruction. So yes, it can, but the goal here would be not to keep it in long enough that it would cause that. And the majority of your juices are coming from your main duct. Yes, you're right, kind of the tributaries are coming down, but the goal here is to keep the majority of them going, and some can kind of seep through and around. Yes, if it stays in a long time, that is a risk. It'll get clogged.
We don't have very set, so it's not uncommon that we have to cut the edges off the
Yeah.
What
Yeah. So, and maybe you guys can comment too, because I'm gonna make kind of something up, but you just interrupt me. Pancreatic duct stents are not permanent. I want them to fall out. So, if the docs are asking you to put in a prophylactic pancreatic duct stent, meaning you didn't do anything, but you accidentally got your wire in there, that can give you pancreatitis, which, as we've seen, is an absolute disaster. So the docs may want to put a stent in there just to kind of allow everything to keep flowing. And those stents are not permanent. So once you put it in there, it should help the pancreas for about 24, 48 hours. And we want it to slip out into the small bowel, and then they'll poop it out. Okay. Other questions? Okay.
All right, guys. So that's just about it for the nursing course. We had a very packed day. I just wanted to thank you all again for coming, whether it have been, down from Highlands Ranch or all the way from, I forget where people have come from, but Minnesota, yeah. So thank you for being here, and I hope that you all enjoyed the course and got something out of it. And the recorded version will be available. Usually it takes a couple weeks. So if you want to have this, and then I don't know if you saw to scan for your CEs, you should also get an email to scan for your CEs if you did not do so already. Do we have any questions? Okay, I think I'm going to release you guys for the day then. Thank you so much for coming. Yeah.